All right, good afternoon, doctor.
Good afternoon.
I'd ask you to keep your voice up and speak into that microphone, all right?
Okay.
Counsel.
Thank you, Your Honor. Good afternoon. Can you please state and spell your name for the record?
Jennifer Tufts, JennifferTufts.
Your date of birth.
December 31st, 1989.
Where do you work?
Astor Mental Health
And how long have you worked there?
for 3.5 years.
What is your role there?
I'm a psychiatrist.
And how long have you been a psychiatrist?
I've been officially fully licensed psychiatrist for close to 4 years.
I want to ask you if you could just explain to us your educational background and your training background that qualifies you to be a psychiatrist.
Absolutely. So I went to medical school at University of Vermont, graduated in 2018 with an MD. I did a postgraduate training in psychiatry at Boston Medical Center. That was 4 years, going into 2022. And then I began working at Astor Mental Health in 2022.
And are you a licensed psychiatrist in Massachusetts?
Yes.
While you were working at Astor Mental Health, did you have a patient named Lindsay Clancy?
Yes.
And at this time, Your Honor, I'd move to submit the records of Lindsay Clancy for Astor Mental Health as the next exhibit.
Okay, they may be admitted.
Do you recall when you first saw Lindsay Clancy as a patient?
Yes.
When was that?
It was in September of 2022.
And was that first appointment on September 15th, 2022?
I believe that it was.
And prior to a patient coming in for their first appointment, is there paperwork that they fill out, either online or that's provided to them to fill out?
Yes.
And what type of paperwork is that?
It's fairly extensive. It includes past health history, past psychiatric history, medications they have taken in the past. It includes names of any therapists or other doctors they work with, usually primary care. It includes any report of substances that they may use or may have used in the past. It includes a number of scales, so scales assessing things like anxiety, depression, ADHD. So it's a fairly lengthy document.
Are you aware that Lindsay Clancy filled out those documents on September 12th, 2022, 3 days prior to her first appointment?
Yes.
And did you have an opportunity to review what Lindsay filled out prior to meeting with her for that first appointment?
Yes.
Okay. And do you recall what you learned from those documents about her prior mental health treatment?
Yes.
What was that?
That she had previously taken some medication. I believe it was in nursing school. It may have been fairly brief, but she had tried the medication Prozac.
Do you recall that she also listed that she had tried Wellbutrin as well while she was on the Prozac?
That was listed as well.
Okay. And do you recall that when she listed that she took the Prozac and the Wellbutrin while in nursing school, she listed that she had no side effects from those medications?
That is correct.
Prozac, is that an SSRI?
Yes.
Okay. So Lindsay reported that she had previously taken an SSRI while in nursing school with no side effects, correct?
Correct.
Did she also report that she had no history of any kind of abuse that had occurred to her at any point in her life?
Correct.
What did she report in regards to alcohol consumption?
I believe she reported 1 to 2 drinks at a time, and possibly up to 5 times a week.
And is there a portion when the patient fills that in, how much they drink? Is there a question there about whether they feel guilty about that?
Yes.
And what was her response?
Am I allowed to go check that just to make sure?
Is there an objection to her reviewing the records?
Yes. She indicated yes.
And so in that section, is it correct that she listed that she was drinking 5 times per week and feeling guilty at that time about it?
Yes.
And did she list her height as 5'6" in those documents? I believe on the same page, page 20.
Yes.
Now, did those that initial survey or questionnaire that she filled out get into what symptoms she was experiencing at the time?
Yes.
And what symptoms did she report experiencing at that time?
Anxiety attacks, decreased appetite, depressed mood, easily distracted, excessive worry, guilt, unable to feel pleasure, unable to fall asleep, and racing thoughts.
And would it be fair to say that there's a checklist of symptoms and the patient checks off which ones they're experiencing, correct?
Yes.
And so on that list, engage in risky behaviors, that was not checked off, correct?
Correct.
And excessive energy wasn't checked off, correct?
Correct.
Feelings of hopelessness, feelings of abandonment, feelings of emptiness, none of those were checked off, correct?
Correct.
Impulsive behavior, that was not checked off, correct?
Correct.
Now, was there also a suicide risk assessment form that Ms. Clancy filled out?
Yes.
And what is a suicide risk assessment?
Well, it assesses various factors that may increase a person's risk of committing suicide.
And the form that Ms. Clancy filled out, the first question is, have you been so distressed you seriously wish to end your life? And her response was no, correct?
I'm just looking.
Page 23.
Correct.
And the second question is, has anything happened recently to make you feel you don't want to live? And her answer was no, correct?
Correct.
There's question 3, a specific plan. Do you have a specific plan of how you would kill yourself? And her answer was no, correct?
Correct.
Fourth question is access to weapons or means of hurting yourself, and the answer is no, correct?
Correct.
The fifth question is made a serious suicide attempt, and the answer was no, correct?
Correct.
The sixth question, purposely done something to hurt yourself? Again, no, correct?
Correct.
Seventh question, heard voices telling you to hurt yourself? Her answer was no, correct?
Correct.
Number 9, having thoughts of killing or seriously hurting someone else? The answer was no, correct?
Correct.
Number 10, heard voices telling you to hurt others? The answer was no, correct?
Correct.
Hurt someone or destroyed property on purpose? The answer was no, correct?
Correct.
In fact, the answers to every question on this suicide checklist was no, correct?
Correct.
Was there also a substance use assessment form that was filled out on page 24?
Yes.
And there were no issues with substance use, correct?
Correct.
Is there also an ADHD self-report scale that's filled out?
There usually is.
Direct you to page 25.
Okay.
And ADHD, is that attention deficit hyperactive disorder?
Yes.
And given the answers that Ms. Clancy gave on that self-reporting form, were there any concerns about attention deficit hyperactive disorder?
Not significantly.
Were there any concerns at all?
Well, she reported often to some of the questions, yes.
And is that significant to you based on your training and experience?
You have to look at this form within the entire picture of the patient. So no, I didn't suspect that Lindsay had ADHD.
So these forms are a tool, and you use them together along with your observations of the patient to come to conclusions. Is that correct?
Yes.
There was also I believe it's entitled a GAD screening. Is that generalized anxiety disorder?
Yes.
Okay, and did Ms. Clancy fill that out as well? Page 27.
Sorry, my pages are a little bit different than yours.
Oh, I apologize.
I'll find it. Okay.
Ms. Clancy's answers to these questions, did they give you cause for concern based on your training and experience?
They were highly suggestive of anxiety and an anxiety disorder.
And for example, number 1, feeling nervous, anxious, or on edge, she responded nearly every day, correct?
Correct.
Not being able to stop or control worrying, she answered nearly every day, correct?
Yes.
And so several of these questions were either nearly every day or several days, correct?
Yes.
I apologize. Can I just ask what page that is?
27, I'm sorry. And then is there also a patient questionnaire that the patient fills out? I think it's...
yes, I believe so. Yes.
And what is the purpose of this patient questionnaire?
I'm not sure exactly which one you're referring to. It might be the one that asks about things like whether the symptoms affect their daily living, what their history is. Is that what you're looking at?
It's entitled Tools-PHQ-9 Patient Questionnaire. And the date is 9/12.
Maybe you want to go over and show her.
Are you able to? Thank you.
Yes.
Okay. Yes.
So this form that's entitled PHQ-9 Patient Questionnaire, what is the purpose of that form?
It's a screening tool for depression.
Okay. And can you talk about the defendant's answers to those questions and what they told you based on your training and experience?
Well, some of the answers were positive, so that really indicates that she should be assessed for depression. She might have it.
Okay. And when you say positive, what do you mean by positive?
So, for example, she said for number 2, feeling down, depressed, and hopeless more than half of the days, a positive response means indicating yes.
So it's not a positive, happy response. It's a positive, this might be an issue response.
Yes.
And on the next form, A1, initial diagnostic assessment.
Yes.
There is a place there, again, well, this is for September 15th, the day you actually met her, correct?
Yes.
So the patient fills out the forms in advance of meeting with you. Do they then again fill out the forms when they meet with you?
No, these are the same forms.
Same forms, just the different date on them?
Yes, because they're included in the intake note, which is what I write, but some of the information is from the patient's self-report.
So would it be a combination of the forms they fill out and then what you observe and ask about during your initial meeting?
Yes.
And that initial meeting with Ms. Clancy, was that in person or was that a telehealth?
Telehealth.
Okay. Does who controls whether it's an in-person meeting or a telehealth? You or the patient?
Both.
Both. And if a patient told you, I don't want to do telehealth, I only want to do in person, is that an option?
Yes.
Go ahead.
Sorry.
I'll let that stand.
And can you just tell us, when you met with Ms. Clancy on that first day, did you ask her questions such as, do you have suicidal intent?
Yes.
What was her response?
That she did not.
Did you ask her if she had homicidal intent?
Yes.
What was her response?
That she did not.
Did you ask her if she was experiencing any auditory hallucinations or visual hallucinations?
Yes.
What was her response?
She did not.
Did you ask her questions to determine if she was experiencing any symptoms of mania?
Yes.
What types of questions you asked to determine that?
Well, a lot of it can be assessed without asking, but questions may look like, have you ever had a period of time in your life where you were excessively energetic and euphoric? I might leave it there and then follow up with some of the other symptoms.
Did any of the questions you asked Ms. Clancy related to mania or manic episodes, did any of her answers to those questions indicate that she had experienced mania or manic episodes?
No.
Now, in that first meeting, what's your exam process? Like, how do you start the meeting and how does it flow?
Sure. So I start the meeting by introducing myself, explaining what we're going to be doing for the day. Then I ask the patient why they're there. We talk about why they're there. I assess for different mood symptoms, anxiety symptoms, psychosis symptoms, mania symptoms, safety concerns. Then we start talking about the history. We start talking about the past psychiatric history, the past medical history, substance use. We start talking about other medicines that they have tried in the past or may still be taking. And it's not always in that order, but that's the general order. Sometimes things come up sooner. And we talk a bit about what the patient's goals are, what they're looking for in this time period, and then I may give some of my recommendations.
And did you follow that process for that initial meeting with Lindsay Clancy?
Yes.
Now, you mentioned that you part of the initial evaluation is looking for signs of psychosis. Is that correct?
Yes.
What types of things are you looking for to see if someone's experiencing psychosis?
So there are a number of things. They start with how the patient appears. So some signs of psychosis might be that they appear disheveled. I assess what their attitude is, if they might be agitated or very uncooperative. That's a red flag. I will assess what their speech is like. Is it very loud? Is it very fast? Or sometimes it could be the opposite, where they're not really even speaking at all. I assess what their mood is like, what they're saying that they're feeling, and how they appear visually. I assess what their thoughts are like. So are their thoughts disorganized, where it's really hard to understand? They're jumping around and you can't follow their line of thought. I assess what the thought content is. If it's particularly about anything very bizarre or very paranoid, that would be potentially indicative of psychosis.
And you conducted that type of evaluation on Lindsay Clancy in that first meeting, is that correct?
Yes, that assessment is done with every patient.
And did you note any signs or symptoms of psychosis with Ms. Clancy that day?
No.
Do you also, in addition to the observations you're making of the patient that day, are you also asking questions about their past behavior and things that have happened to them in the past that might indicate whether psychosis is an issue?
Yes.
And what types of things are you asking them about their past?
Well, I may ask, have you ever heard voices? Have you ever seen something that other people didn't see?
And did you ask those questions of Ms. Clancy?
I believe I did.
And what was her response?
No.
Do you, and as part of this evaluation, are you making an assessment about the patient's judgment and insight?
Yes.
And when we talk about psychiatry, what are we talking about when we say judgment?
So judgment indicates their decision-making process, and whether it is a logical decision-making process or perhaps not.
And same question in terms of insight. What does that mean in psychiatry when you're assessing their insight?
So that's more about a patient's awareness, both of their inner feelings as well as mental health a bit more broadly.
And in terms of orientation, when you're assessing a patient, what does that mean?
Orientation is awareness of where someone is, who someone is, what day it is, what's going on.
And based on your evaluation of Lindsay Clancy that first day, September 15, 2022, did she appear to have any issues with judgment, insight, or orientation?
No.
Do you also assess the patient's memory?
Yes.
And how do you do that?
Well, it depends. Often, unless there is a specific concern about memory or dementia, it's based off of my conversation with them. Are they able to recall medications that they have taken? Are they able to recall, things that they have done with a lot of detail and specificity?
And did there appear to be any issues with Lindsay Clancy's memory in your evaluation of her?
No.
And what about attention and concentration? What are you looking for as a psychiatrist when evaluating attention and concentration?
I'm looking for whether they're paying attention to the conversation, if they can follow it, or maybe if they get distracted, it seems like they're not listening, something like that.
Did Lindsay Clancy appear to have any issues with attention or concentration?
No.
There was something in the records called fund of knowledge. What does that mean?
So basis of knowledge, what someone understands about the world. So maybe if somebody has a very low education, they might have a low fund of knowledge.
And was there any issue with Lindsay Clancy's fund of knowledge?
No.
Are you also assessing mood?
Yes.
And how do you assess the mood of a patient, and why do you assess it?
Well, it's very important. The mood is based on what the patient says, what they say about how they're feeling.
Okay. And so are there circumstances where a patient might say they're feeling happy, but you make observations that they appear depressed?
Yes.
Okay. And so when we see mood in the records, that refers to how the patient is reporting their mood is?
Yes.
So if it says appropriate mood and affect, or actually if it says patient description of their emotional state, it says okay, does that mean the patient said okay?
Yes.
Is there a place in the record where you describe what your observations of the mood are?
That's the affect.
Affect, okay. And so affect is how the patient presents?
Yes.
This first meeting with Lindsay, what was her mood?
It was okay.
And what was her affect?
Anxious.
So she was reporting to you, she felt okay. You were seeing she looked a little anxious.
Yes.
How do you, or what is it about a person that tells you they look anxious? Like, what were you seeing with Lindsay Clancy that told you she looked anxious?
It's hard to recall exactly what she seemed like. Sometimes, a person might look anxious by...
Sometimes, Your Honor.
All right, sustain.
In your general observations of patients, what things would you look for in a patient to determine whether their affect is anxious?
Is their voice quivering? Are they shaking a little bit? Do they appear very nervous?
And what is psychomotor behavior?
So psychomotor behavior refers to someone's body and their movements. So sometimes that can be abnormal.
Okay. And did you notice anything abnormal about Lindsay Clancy's psychomotor behavior?
No.
This first meeting, was that approximately 40 minutes?
It was a little bit longer than that, maybe 50 to 60 minutes.
Is that typical for that first meeting where you're doing this initial assessment?
Yes.
And did she appear alone in that virtual meeting, or was she with anyone?
Alone.
And what are treatment modality and interventions in general?
So that section is referring to therapy treatment modalities. It's not asking about medications. So different forms of therapy that might be done in the session.
And what would be treatment goals?
Goals that we are working on or will plan to work on, since this is only the first visit.
So how do you determine for an individual patient the treatment modality or interventions that are needed?
It depends on the patient.
So basically on what you're seeing, what you're hearing, and the history they provide?
Yes.
And how do you determine treatment goals?
So a lot of that is driven by what the patient's goals are.
And you mentioned earlier that as part of your evaluation, you asked the patient why they've come to you, what they're concerned about. Do you recall Lindsay's response to that question, why she was there, what she was concerned about?
I believe her biggest concern was about anxiety.
And what was the treatment modality or interventions that you determined would be needed for Lindsay Clancy based on this initial evaluation?
So I recommended a medication sertraline as well as individual therapy.
And the medication sertraline, is that Zoloft?
Yes.
Okay. And when you say you recommended the Zoloft to her, was that you telling her you have to take this medication, or did you have a discussion about it?
A discussion.
And during that discussion, did you get the patient, Ms. Clancy's, input on whether she wanted to take the medication or what her thoughts were about the medication?
Yes.
And do you recall the details of that conversation with her?
I recall that she was generally reluctant to take medications, but at this point she was considering it and was interested in learning about what medications might be helpful for her.
And as part of that discussion, did you explain what the medication was and the side effects and all of that?
Yes.
And did she have any questions for you based on your explanation of what the medication was for and what the side effects could be?
I'm not sure.
And why did you recommend that particular medication?
So it's a first-line medication used for treating anxiety disorders. It also is a first-line treatment when women are breastfeeding. It's the safest SSRI for babies.
And when you say a first-line medication, what does that mean?
It just means it's one of the medications that is recommended first. Sometimes you have to try a number of different medications, but that is often a first choice.
And is that based on studies and the experience of the psychiatric profession?
Yes.
What was the dosage that you recommended or prescribed for her for the Zoloft?
25 milligrams.
And were there instructions on the prescription in terms of how many milligrams to take the first week and then how many to take the second week?
Yes, it was 25 milligrams for 1 week and then increasing to 50 milligrams.
And that was your initial prescription and what should have been on the pill bottle, correct?
Yes.
Was there ever a call from the defendant where she called you and said that she was having trouble with the 25 milligrams and you recommended her go to the 50 milligrams?
No.
You said you also recommended therapy, is that correct?
Yes.
And asked her mental health, did they have therapists on staff that you referred Ms. Clancy to?
Yes.
And do you know if she took advantage of that, that resource?
She did.
Do you know which therapist she saw?
Yes.
Who was that?
Jennifer McAllister.
And how does it work when a patient is at Astor Mental Health, they're being seen by a psychiatrist, they're being seen by a therapist? Is there someone that's kind of in charge of the treatment of the patient that oversees everything, or is it all just individual?
The psychiatrist is in charge.
Okay, so you would have been in charge of Ms. Clancy's treatment?
Yes.
And as part of being in charge of her treatment, would you review the records from her therapy sessions to inform and guide your treatment of her?
Yes.
What were the treatment goals for the defendant?
I don't recall exactly what her words were.
Would the goals be what your patient tells you?
Yes.
Okay. I'm going to approach and just ask that you look at page 41 of the records for Exhibit 219 to the treatment goals section. Does that refresh your memory?
Yes.
And what were the treatment goals according to Ms. Clancy?
So these are not her words. There's a list in the electronic medical record where I can indicate which ones might apply, or I can type out my own. So the treatment goals based on what we had decided on together were symptom reduction and improved functioning.
And you said that Ms. Clancy had been a little reluctant about starting medication. Did she tell you why she was reluctant?
Yes.
And why was that?
She was worried about having side effects.
And did she mention which specific side effects, or just side effects in general?
I thought it was in general.
And as a result of that concern, is that when you went over the potential side effects of Zoloft?
Yes.
And after having that discussion and you explaining the side effects of Zoloft, how did the two of you leave it in terms of whether she was going to take the medication or not?
I told her what my recommendation was, that she should start the sertraline. I'm not sure if she told me definitively if she was going to take it or not. She might have needed some time to think about it.
And based on your evaluation with Ms. Clancy, everything you learned about her history and how she presented that day, did you have an initial diagnosis?
Yes.
And what was that?
It was a generalized anxiety disorder, and it was an adjustment disorder with depressed mood.
What is generalized anxiety disorder?
It's an anxiety disorder where an individual may have a lot of different worries. They may also have physical feelings of anxiety, but they're worried about a lot of things, not really just one thing specifically.
And what is adjustment disorder with depressed mood?
So adjustment disorder refers to the fact that there may be symptoms, but they are kind of secondary to the situation. So they don't meet the full criteria, say, of a major depressive disorder, but there were some symptoms of depression.
Is this a good place
Yes.
to start? All right. Members of the jury, this is, it's 1 o'clock.
So, Dr. Tufts, back on that first appointment with Ms. Clancy on September 15th, 2022, as part of the record, did you detail a section, history of present illness?
Yes.
And in that section, you put in here initial presentation, nursing school, Prozac helped, got treatment after second baby, 2 for anxiety, Zoloft 1 week, was nervous about breastfeeding, initial side effects. Can you just tell us where that information came from?
My conversation with the patient.
Okay. And where it says Zoloft 1 week, was nervous about breastfeeding, what does that mean?
So she had tried Zoloft before during the postpartum period after her second baby.
And did she tell you whether she had any side effects when she took Zoloft after her second baby?
She mentioned something about initial side effects, which are pretty common for many people. I didn't detail what those side effects were, but they sounded like the very normal ones that people might experience that are transient in the beginning of the treatment.
And what would those side effects be?
Possibly upset stomach, appetite issues.
I apologize. Can we know what related to this patient rather than somebody?
All right, so why don't you ask if she remembers what the defendant said the side effects were?
Do you remember what the defendant said the side effects were?
I don't remember them exactly, but they were ones that did not seem concerning.
And in your experience, in your training and experience as a psychiatrist who prescribes Zoloft, what are the common side effects that you deal with, that patients deal with from this medication?
So in the first couple weeks of treatment, we described that there's a lot of serotonin in the gut as well as the brain. So the medicine often affects the gut first. So you might have diarrhea, constipation, difficulties with appetite, nausea, things like that.
And you also wrote in the note about history of present illness, 3 months postpartum, also 4 and 2-year-old feeling overwhelmed. Is that correct?
Yes.
And that came from the patient, Ms. Clancy?
Yes.
And furthermore, you wrote that the baby needing more attention, other kids more challenging too. Is that coming from the patient?
Yes.
And does she also describe she's having trouble leaving the baby, too anxious to do anything when she leaves, physical tension, heart racing, worries he won't eat or sleep because he's refusing the bottle?
Yes.
And did she say that makes her irritable?
Yes.
And in that same note is where you detail that she denied audio hallucinations, visual hallucinations. You also, correct?
Yes.
And you also detail suicidal ideation, homicidal ideation, denies, no concern about hurting baby. Is the no concern about hurting baby, is that an observation you're making or something that came from Ms. Clancy?
It came from our conversation.
So at some point in time, she told you she had no concerns about harming the baby.
Yes, it was.
I object.
Just an objection? If you could rephrase that question.
What did she tell you about her thoughts about the baby?
I asked if there were those thoughts, and she denied them.
And did you also provide information to her about what to do if in between appointments there were emergencies or issues?
Yes, I believe that I did. I usually do when I meet a patient.
And in the page describing treatment follow-up plan, which would be in the initial diagnostic assessment from September 15th in that treatment follow-up plan section, there's a part there that says, if having urges to harm self or others, go to the nearest emergency room, call 911, or call the National Suicide Prevention and Crisis Hotline, correct?
Yes.
Is this page given to the patient?
They can access it online on the portal.
So Ms. Clancy would have the ability to go on here, look at the portal, and see what to do if she was having a crisis.
Yeah, just this this plan section, yes.
Just the treatment plan section.
Yes.
So is it that she would have to search through the records, or is that something you can click on to see the treatment plan?
I'm not sure exactly what it looks like for a patient.
Okay. But that's one of the sections that's available to the patient, Lindsay Clancy, if she goes onto the portal.
Yes.
There's also in here, if you feel you're in crisis, you may text home to a certain text number from anywhere in the United States. Is that correct?
Yes.
And what does that do when you text that text number you text home to that text number?
It connects you to a counselor.
Now, what was the treatment or follow-up plan for Ms. Clancy?
To start the search for Lean, to start individual therapy, and to follow up with myself.
So your recommendation wasn't just that she take pills, you recommended that she attend therapy, correct?
Yes.
And when you recommended the therapy, did you, and the medication, did you also go over with Ms. Clancy alternatives to the medication that you were recommending?
I believe she was aware that the alternative was that she could not take a medication, which is what she had been doing before.
And after you went over all of this information with Ms. Clancy, did she convey to you that she understood the plan and was agreeable to the plan?
Yes.
What is informed consent?
Informed consent means you communicate with a patient what the risks and benefits are of treatment, and they understand that and they agree to the treatment.
And did Ms. Clancy show that she had informed consent to everything you discussed?
Yes.
Now, was your next appointment with Ms. Clancy on September 28th, 2022?
Yes, it was.
And so during that appointment, did you discuss the medication, the Zoloft, that you had prescribed to her?
Yes.
And what did you learn from Ms. Clancy about whether or not she had taken that medication?
She shared that she decided not to take it.
Did she tell you that she had picked it up but had decided not to take it?
Yes.
Did she tell you how she was feeling?
She said a little bit better.
And did she elaborate on that?
The baby was getting some more sleep, so she was also able to get some more sleep, and that helped her feel better.
And at this appointment, did you go through a mental status exam of Ms. Clancy?
Yes.
And what is a mental status exam?
So a mental status exam is an assessment of the patient at the point of meeting. It can change at different times, but it's comprehensive, referring to how the patient appears, how they cooperate, how they speak, how they describe their thoughts, how they're able to communicate with you, and what their mood is like.
And do you do that at every appointment with every patient?
Yes.
And so on the September 28th, 2022, when you met with Lindsay Clancy for that second meeting, did you do a mental status examination?
Yes, I did.
And what was the result of that?
So I can, is it okay if I read it from the note, or do you just want me to?
There's no objection?
Go ahead, you may.
She was alert, she was oriented, she was appropriate, her rapport, meaning how she worked with me, was appropriate, dressed appropriately, euthymic, meaning not depressed, not angry, kind of a normal mood. Her affect was full, her speech was appropriate, her thought content and a process were appropriate. She did not mention any hallucinations. At this point, I mentioned her insight was poor, her judgment was excellent, her cognition was did not show any deficits, and there was normal psychomotor activity.
And why did you list that her insight was poor?
So I think that must have been related to the fact that at this point, she did have some very clinically significant anxiety. Usually when people come to a psychiatrist. They believe that their symptoms are significant and that a medication is something that might be prescribed. But despite these symptoms, she still didn't want to try the medicine.
And what is the difference between a psychiatrist and a psychologist?
So a psychiatrist is a medical doctor. We go to medical school and then we specialize in psychiatry. A psychologist does not go to medical school. They may do a lot of research in their training. They may learn a lot about psychotherapy, but they don't learn about the human body, about how we metabolize medications and things like that.
And so can a psychiatrist prescribe medication?
Yes.
Can a psychologist prescribe medication?
No.
Now, in the medical records exhibit 219, page 47, it lists here recent lab work, no lab results were found. Is it that you had ordered lab work and you couldn't find the results, or that none were ordered?
None were ordered.
And why is that?
It was not necessary.
And why isn't it necessary at that point for Ms. Clancy to order blood work?
There's no blood work that is commonly done when a patient presents with generalized anxiety disorder and no other medical complications.
What types of situations would you order blood work for?
I mean, there could be a lot. Certain medications require laboratory monitoring, maybe something that, could affect the kidneys or could affect the thyroid, could affect the cholesterol. These are things that we monitor to make sure that the medicine is prescribed safely.
And so Zoloft, is that not one of the ones that would need to be monitored because of its potential effects on the body?
Correct.
And at that time, she reported to you she wasn't even taking it yet, correct?
Correct.
And your appointment that day, I think according to the records, it was approximately 17 minutes long. Is that correct?
So can I explain that?
Absolutely.
Because I think there's a bit of a misunderstanding. So the 17 minutes, I think people are looking at the note where it says a therapy start time of 10 a.m., a therapy end time of 10:17, so they're calculating 17 minutes. But those timestamps are specifically related to the therapy portion of the exam. They're not reflective of the complete duration of time when I met with her.
So what would be the complete time that you met with her on that day?
So I don't know the exact amount of minutes, but the appointments are 25-minute appointments, so it would be more or less a few minutes, about 25.
And so the 17 minutes that are for the therapy portion of the appointment, what comprises therapy? What does that involve?
It really varies based on the person, based on the situation. It can involve, providing some emotional support.
I apologize. Can we talk about Lindsay Clancy rather than in general? That's all.
It's
I'm going to allow a little bit of the background, so that then we'll move into the defendant.
Thank you. So you were saying that therapy portion is kind of talking to the patient, seeing how they are, and getting an assessment of their current mental state?
Yes.
And the other 8 minutes, typically, what happens in those 8 minutes?
That's more focused on specifically medications and medication management.
So these appointments that you had with Lindsay Clancy, when it says 17 minutes, that's the therapy, the talk portion of the appointment, and then there was a separate portion where medication was discussed?
Yes, in the real world, those two segments are intertwined. So it's not necessarily that we say, this is the end of your therapy component. It's a bit more seamless than that.
Okay. Now, in your training and experience in the way you conduct your practice, if you're having a therapy portion or you're conducting therapy with a client and that 25 minutes has run out, is it a hard stop or is there an option to continue?
It's not a hard stop. I do have limitations because I have other patients that are waiting. But if there's something urgent, I can go a little bit over. If there's an emergency, I can cancel the next patient if I have to.
And these 25-minute appointments that you have, if a patient were to request a longer appointment with you, is that available?
It's an option.
Did Lindsay Clancy ever request a longer appointment time with you?
No.
Now, that appointment on September 28th, 2022, was that also a virtual appointment?
Yes.
And did Ms. Clancy appear to be alone in that virtual appointment?
Yes.
And based on your conversations and assessment of her on that day, what was the plan going forward?
So at this point, she was improving, and we decided to pause on the medication question and have her meet with one of our therapists.
So that first appointment was on September 15th. You recommended therapy. The next appointment was September 28th. So had Lindsay not scheduled a therapy appointment yet with Jennifer McAllister at that point?
I'm not sure when she called to schedule that.
And but that was the plan going forward, that your recommendation was that she attend therapy with Jennifer McAllister?
Yes.
And did Ms. Clancy seem receptive to that plan?
Yes.
Did she tell you she was going to make an appointment with Ms. McAllister?
Yes.
Now, according to the records, the next appointment was October 3rd, 2022, just 5 days later. Was there a reason that you had such a short time span between that September 28th appointment and the October 3rd appointment with Ms. Clancy?
I believe that the patient must have scheduled the appointment on her own, and that's why the span time was rather short.
Do you recall Ms. Clancy reaching out to you about getting paperwork for a maternity leave extension?
Yes.
And did she reach out to you through the portal for Astor Health?
Yes.
And did you respond to her on that portal?
Yes.
And did you fill out paperwork for her to extend her maternity leave?
I think that I did.
And so there is a message from Ms. Clancy to you on September 30th, 2022 in the portal that states, "Hi, Dr. Tufts. Thanks again for all your help at our last 2 appointments. While I am feeling just better enough to function without medication, I did reach out to my employer about extending my leave for reasons of postpartum anxiety/depression. I don't feel mentally well enough to return to taking care of patients with a baby at home that still won't take the bottle. I know this will trigger my anxiety too much, and also having to stay up all night as a nurse, I don't feel it's possible right now. They asked that my provider could fill out a form so they could process this request. Can I please send you the form to fill out?" And you responded on September 30th, 2022 at 2:41 p.m. This type of paperwork often requires a lot of information, so it's best if we go through it together in an appointment. Do you recall that?
Yes.
So would that have been why the October 3rd appointment was set up?
That may have been, yes.
And then do you recall receiving a message from Ms. Clancy on October 10th, 2022, stating, "Hi, Dr. Tufts, there is a part on the serious health condition form that you filled out for me that needs to be changed. On the second page, you put I could work a reduced schedule of 8 hours per day, 2 days per week. However, we discussed not working at all until January 1st. I think we talked about when I return to work, that is what I could do, but that the way it appears on the form makes it seem like I can do that now. Do you still have the form to make the adjustment, or do I need to send it back to you? And then you responded that you would send back an updated version. Is that correct?
Yes.
So do you recall having a conversation with Ms. Clancy at the October 3rd appointment about not returning to work and how long she should be out of work for?
I recall having a conversation about that.
And that January 1st date, was that something you decided or something Ms. Clancy requested?
I think it was something that we decided together.
And in that appointment on October 3rd, did Ms. Clancy tell you that she was on the verge of taking the medication?
Yes.
And did you discuss that with her?
Yes.
And what was that discussion?
Well, she was having more anxiety again. It seemed like maybe it had started getting better, and then it was kind of where it had been when she initially reached out. And so she was feeling like a medication might be helpful.
And did Ms. Clancy tell you at that appointment that she wanted to try therapy before taking the medication?
Yes.
But she had not had an appointment with Jennifer McAllister yet, correct?
I'm not sure what date her first appointment was with Jennifer McAllister.
Showing you page 57 of Exhibit 219. An initial therapy assessment by Jennifer McAllister on October 3rd, 2022. Would that have been the first time she saw Ms. McAllister?
Yes.
So that's on that same day that you saw her. It looks like from the records you saw her at 11:30. Is that correct?
I don't have the time on my paper, but I'm sure that's correct.
Okay, so apparently she saw you about the work form, and then she had an appointment with Ms. McAllister. Is that correct?
Yes.
And it says here in the records that Jennifer McAllister is an LMHC. What is that?
A licensed mental health counselor.
And so is a counselor, a licensed mental health counselor, someone who can conduct therapy sessions?
Yes.
And why is it in your practice that you have a psychiatrist who does therapy and prescribes medication, but in addition, you would have a therapist doing counseling?
So today, a lot of psychiatry is practiced as a team. At least that's how we practice at my office. So oftentimes the therapist is able to see the patient every single week. They're able to focus in more depth on certain aspects of the patient's well-being, and so it's helpful to have one person paying extra attention to the therapy component, especially when the psychiatrist does have to spend a lot of time discussing the medications and thinking about the medications.
And so is that the teamwork approach that Lindsay Clancy received in her treatment at Astor Mental Health?
Yes.
And in that October 3rd assessment with Ms. McAllister, you reviewed those notes and records so that you could properly treat Ms. Clancy, correct?
Yes.
And in that first meeting with Ms. McAllister, the defendant described her relationship with her parents as very supportive and stable, correct?
I don't have Jennifer's notes in front of me.
Showing you page 60. You want to just review the notes?
Sure.
Look up when you finish. Does that refresh your memory as to the notes that you reviewed from Lindsay's session with McAllister?
Yes.
And so in that session, Ms. Clancy stated that her parents were very supportive and stable.
Yes.
And She also mentioned having the support of an older sister who only lived 2.5 hours away. Is that correct?
That's what she stated in the note to Jen.
Did she also say that she was not close with her in-laws who lived in Scituate? She would see them often as they were her husband's parents, but she didn't generally allow them to watch the children. Is that correct?
That's what I read.
And there's a quote in here, don't have a particular reason why, they don't bug me about it either. Is that correct?
That's what I read.
And October 3rd, 2022, when you met with her that day, did you again do a mental status exam?
Yes.
Had anything changed in that mental status exam from the September 28th meeting that you had with her?
Can I review it?
Yes.
I mean, there isn't anything that stands out to me right now.
And I think that what you put on the October 3rd date was that her insight was still poor.
Yes.
Was that for the same reasons you described earlier?
Yes.
The next time that you saw Ms. Clancy, was that on October 20th, 2022?
Yes.
And what information did you learn on that date about whether or not she was taking the Zoloft you had prescribed?
So she told me that she decided to start the Zoloft.
And did she tell you how long she had been taking it?
For 1 week.
And did she tell you that the previous night she had increased the dose?
Yes.
And that's what was in the original prescription, correct? To take the pills at 25 milligrams for 1 week and then increase to 50?
Yes.
So if that had been done, taking the pills for 1 week would be 7 pills, and then increasing the dosage the next night would be 2 pills?
Yes.
And so that would be 9 pills?
Yes.
When she told you she increased the dose, she told you she now feels awful, is that correct?
Yes.
And what was it that was bothering her?
She was having increased difficulty sleeping. She had loss of appetite, diarrhea. She was feeling her mood was down. She was tearful and feeling very foggy and feeling very anxious.
Now, what is the lowest dose of Zoloft that you would prescribe a patient or could prescribe?
The smallest pill is 25.
And what's the highest dose of Zoloft?
200.
Okay. So she was on the lowest dose of 25, is that correct?
Yes.
And then according to what she told you, she had increased for 1 night to 50 milligrams, is that correct?
Yes.
Did she also tell you she was scared to start something new?
Yes.
Is that in terms of another medication?
Yes.
So what was your discussion with Ms. Clancy when she's telling you that she's having these issues with Zoloft, but she's afraid to try something new?
So we discussed what to do moving forward. So we discussed whether it would make sense to switch to a different medication at that point. And at that moment, because of her negative experience with the Zoloft, she did not want to start a new medication at that point.
At this meeting with her, did you ask her if she had any suicidal thoughts?
Yes.
What was her response?
No.
Did you ask her if she had any homicidal ideation or thoughts?
Yes.
What was her response?
No.
Did you ask her if she was hearing any voices or seeing any visual hallucinations?
I'm not sure if I asked that in that appointment, but she was very clearly not psychotic.
And why do you say that?
Because of how I described some of the signs of psychosis that are on the mental status exam, none of those were present.
Okay. What was her affect during this meeting?
It was depressed.
And did you write that that she was, strike that? What was it about her affect that made you write that she was depressed?
She visually appeared like she was feeling sad.
And her mood, how did she report that to you?
That was depressed as well and anxious.
What about her thought content and process that day?
That was appropriate.
And her speech?
It was appropriate.
And her judgment and cognitive skills?
Her judgment was excellent, and her cognition didn't have any deficits.
And her psychomotor activity?
Normal.
So the main change here from previous visits was that she appeared depressed and anxious.
Yes.
Although she had appeared anxious that first visit, correct?
Yes.
So to make sure we have the timeline correct, the first visit she appeared anxious, the second visit she appeared to be doing better, the third visit she still had that poor insight when you met about the paperwork, and then this fourth visit she appears depressed. Is that correct?
Yes.
Did she also tell you that she was worried about getting suicidal thoughts?
Yes.
So that would have come directly from her, correct?
Yes.
And what was that? What were the details of that conversation?
So it was one of the things that she was anxious about. It was a fear of one day having suicidal thoughts if she were to continue to feel poorly.
Okay. And showing you page 77 of Exhibit 219, I know you said earlier you weren't sure if you asked her about audio or visual hallucinations, but just directing your attention to the interval history, if that refreshes your memory.
Yes.
So did you ask her about audio hallucinations and visual hallucinations?
On the 21st, I did.
Okay. All right, so then there was an appointment the following day on October 21st?
Yes.
So why did she have an appointment that following day?
Because she was feeling pretty poorly after starting the Zoloft, so we were following her closely.
And at that point, you knew that she had had an appointment on the 3rd with Ms. McAllister, correct?
Yes. And
do you know whether or not she had followed up making another appointment or was struggling with that?
She was planning on making another appointment. I don't know when that second appointment was scheduled.
When that first appointment where she was seeming depressed and having issues with Zoloft on October 20th, did you tell her to stop taking the medication at that point?
Yes, I did.
Okay. And did you discuss other options with her other than medication, like natural remedies?
Yes.
And what type of natural remedies did you discuss with Ms. Clancy?
So I mentioned things like fish oils, something called L-methylfolate or SEAM. These are supplements.
And why would you offer alternative remedies to a patient?
So it was because she seemed reluctant to start a prescribed medication. I thought she might be more open to something that was natural.
So you weren't pushing her to take a prescription medication, correct?
No.
Now, on October 21st, when you saw her, did she tell you that she hadn't been able to get any sleep the night before?
Yes.
You've already said she told you she wasn't having audio or visual hallucinations, correct?
Yes.
Did you ask her if she was having suicidal ideation or homicidal ideation?
Yes.
And what was her response?
No.
What was her affect that day?
It was depressed.
And did she tell you during your conversation that day that she had been anxious all day, not depressed or irritable, getting better?
Yes.
Okay, so she's telling you she's not depressed, but her affect to you appeared depressed. Is that correct?
Yes.
And is that for the same reasons you stated earlier, those visual cues that you saw?
Yes.
Did she appear hyper or manic in any way?
No.
Was there any changes in her rate of speech or pattern of speech?
No.
Was there any difference in her mental status exam?
No.
And this appointment, was this appointment virtual as well?
Yes.
Had all your appointments up to this point been virtual?
Yes.
Was she alone in that virtual meeting?
Yes.
What was the plan that was formulated on October 21st?
So the plan was that she start a medication called Ativan to be taken as needed, which means not necessarily every day, but in the instance of severe anxiety.
And how did you explain to Ms. Clancy when to take the medication?
I don't remember exactly how I explained that.
So in general, as a psychiatrist, when you're prescribing a medication like Ativan and you're telling a patient to take as needed, what does that mean?
So it means when the symptoms are present, and in this case in particular, when the symptoms are severe.
So with Ms. Clancy, what were the symptoms that she was experiencing that made you decide that Ativan would be an appropriate medication?
Anxiety.
So would it be when she was feeling anxious, feeling those symptoms of anxiety, that she should take the medication?
Yes.
And what was the dose again?
0.5.
What's the lowest dose of Ativan you can give?
0.5.
What's the highest dose?
Maybe 2.
Okay. So you started her at the lowest dose, the 0.5.
Yes.
And was there a specific time frame that you wanted her to try this in?
Yes, this was for 1 week.
And was the prescription for a 1 week amount, or is it hard to tell that because it's as needed?
It's hard to tell that without seeing exactly how many pills were prescribed.
And was there also, again, a recommendation to go to Ms. McAllister for therapy?
Yes.
And when were you recommending follow-up with Ms. Clancy?
1 week.
And why a short turnaround at this point?
Because she was still having very significant symptoms.
And did you in fact see her on October 26, 2022?
Yes.
And at that appointment, what was Ms. Clancy's affect?
Depressed.
What was her mood according to her?
It was anxious and depressed.
And did you discuss with her whether she was taking the Ativan and whether it was working?
She said that it was not helpful for her sleep, but it made her feel less anxious.
And in this appointment, there was a discussion of Benadryl. Is that correct?
So she reported that Benadryl was something she had tried and it was helpful. It was taken over the counter.
Had you recommended or told her to take the Benadryl at that point?
I don't think so.
And so when you met with her and she told you that she had taken the Benadryl and it had helped, what was your reaction to that?
I was glad that something was helping.
And did she tell you how often she was taking it or how much of it she was taking?
I don't recall.
Did you ask her that day if she had any suicidal or homicidal ideation?
Yes.
And what was the response?
No.
Did you see any signs of psychosis that day?
No.
Up to that point on October 26, 2022, had you ever had any difficulties in communicating with Ms. Clancy?
No.
And ever any difficulties understanding her or thinking she wasn't understanding what you were saying?
No.
At this appointment on October 26, 2022, did she tell you that she had scheduled an appointment for therapy with Ms. McAllister?
I don't remember. Oh, yes, she did. She said she has an upcoming appointment.
And what was the plan after meeting with Ms. Clancy on the 26th?
So at that point, we discussed trying a new medication because she felt that whatever side effects were caused by the Zoloft had resolved, but she still had the same anxiety that she had had beforehand. So we discussed starting the medication Buspar at 5 milligrams twice a day.
And what is the lowest dose of Buspar?
5 milligrams.
And what is the highest dose you can prescribe?
The pills probably come up to 30 and multiple 30 pills taken per day.
So you could prescribe someone more than 30 milligrams per day?
Like a total dose of 60.
Okay. So you started her again at the lowest dose?
Yes.
And why did you choose Buspar?
So Buspar is very well tolerated. It's a very mild medicine, especially for someone who is experiencing side effects from another medication.
And what does Buspar do?
It lowers anxiety.
And was she to continue taking the Ativan with the Buspar?
She could continue taking it as needed if she were to have those extreme moments of anxiety.
So would it be that the Buspar was twice a day, and then if she felt really anxious, she could take an Ativan?
Yes, because given that low dose of the buspirone, it might not have been enough of a dose to be effective right away.
And Buspar and Buspirone are the same thing?
Yes, sorry.
There's also a note in here prescribing hydroxyzine 25 milligrams daily as needed for anxiety. What is that?
Hydroxyzine is an antihistamine. It's similar to the Benadryl that she had been taking for sleep. So I recommended that she try the hydroxyzine. It is a safer medicine to take compared to the Ativan. So if someone is feeling very anxious and they can take a hydroxyzine and that prevents them from needing to take the Ativan, that's good. So I wanted her to at least try that option instead.
So you gave her several options on how to deal with the anxiety as it appeared each day. Is that correct?
Yes.
And why take hydroxyzine, which is an antihistamine, instead of just taking the Benadryl?
So they're very similar, but hydroxyzine is indicated for anxiety, whereas Benadryl is really indicated for allergies.
And you discussed this plan with Ms. Clancy, and did she agree to that plan?
Yes.
And in discussing it with her, did you go over all the possible side effects and the interactions of the medications that you had prescribed?
Yes.
And did she voice any concerns about any of that?
No. I mean, I think she was still apprehensive about starting a new medicine and about potential side effects, but nothing specific.
Okay. So it was a general concern about medication in general?
Yes.
But after you had the conversation and explained what you were recommending and prescribing, did she agree to that plan?
Yes.
And was there any change in her mental status that day?
No.
Now, going to the next time that you saw Ms. Clancy, was that October 30, was her next appointment on October 31st with Jennifer McAllister?
Yes.
So you were able to review in the records in preparation for your next appointment that she had, in fact, went to a therapy appointment. Is that correct?
Yes.
And the therapy appointment, was that approximately an hour-long appointment with Ms. McAllister?
Yes.
When was your next appointment with Ms. Clancy?
November 2nd.
And on that date, was that also a virtual appointment?
Yes.
Do you know whether the therapy appointment with Ms. McAllister was in person or virtual?
I'm not 100% sure, but I think it was virtual.
Okay. And up to this point, had Ms. Clancy ever told you that she didn't want to do virtual, that she wanted to come in person?
No.
Now, on this November 2nd appointment, did you have a discussion about the abuse bar?
Yes.
And what was that discussion?
So she did not start it. She was too afraid to start a new medication.
Did she tell you that she had continued with the Ativan and the Benadryl?
She said she continued with the Ativan.
Ativan. Was there any further discussion about the Benadryl or the other antihistamine that you had prescribed, the hydroxyzine? I hope I'm saying that correctly.
You are, and I'm not sure. I don't think there was much conversation about the Benadryl or the hydroxyzine.
Okay. And what was her affect that day?
It appeared appropriate.
And what was her mood? How did she report feeling?
Euthymic.
What does that mean?
Euthymic means a normal mood, not necessarily sad or angry or euphoric. It's just kind of neutral in the middle.
And would that have been a word coming from Ms. Clancy or just how you describe the word you used to describe?
It's a clinical word.
Clinical. Did you ask her if she had any suicidal or homicidal ideation?
Yes.
What was her response?
No.
Did you see any signs of psychosis present in her that day?
No.
That day, did you discuss alternatives to Ativan?
Yes.
And why were you discussing alternatives to the Ativan?
Because Ativan was not a medication I intended for her to be taking for a long period of time. It was a short-term medication.
And why is that?
Because it does have a risk of dependency when people take it for a long period of time, and especially at high doses.
So did you bring up this discussion about alternatives to Ativan, or did Ms. Clancy ask about it?
I think that was something I brought up.
And what were the alternatives that you discussed with her?
Remeron, trazodone, pregabalin, and hydroxyzine.
And what was it about those medications that you thought they would be appropriate for Ms. Clancy?
That they might be safer medications that could also help her with sleep, also help her with some of the anxiety.
And how are they safer?
So they don't have that risk of the dependency.
And while you're interacting with her and discussing the alternatives to Ativan, what was her mental status that day? Was there any change in it?
No.
And so after this discussion with her about the alternatives, was there a decision made on how to proceed?
Yes. So we discussed tapering the Ativan by 0.25 milligrams every 2 weeks.
And what does tapering mean?
It means slowly reducing.
And why do you slowly reduce the medication?
So when you are taking Ativan, like I mentioned, the risks of dependency, there's also risks of withdrawal symptoms if a medication like that is abruptly stopped. So that's why we gradually decrease it.
And so if the plan was to decrease it by 0.25 milligrams a week, what amount was she taking per week?
So it was by 0.25 milligrams every 2 weeks.
Oh, 2 weeks, okay.
So at first we were decreasing it from 1 to 0.75.
Okay. So it was a 1 milligram pill that she was taking, and then she would just take less and less and less until she wasn't taking it any longer?
Yes.
Okay. And then had you, with Ms. Clancy, decided on a replacement for the Ativan?
At this point, I don't think there was a medicine that we had decided on.
Okay. So the plan at that point was just to taper off the Ativan, but nothing was added at that point?
Yes.
Did you next see Ms. Clancy on November 22nd, 2022?
Yes.
And do you recall why there was a 20-day gap between seeing her on the 2nd and then seeing her on the 22nd?
Well, I'm not sure. I would really be guessing if I said.
Okay. Did you learn at that appointment on November 22nd of 2022 that Ms. Clancy had started another program?
Yes.
And what program was that?
It was a South Shore perinatal mental health clinic.
And was that the first that you learned of Ms. Clancy being involved in that program?
Yes.
Did she tell you she was thinking about doing it, or that she was already enrolled in that program?
That she was enrolled in it, and that what it sounded like she was going to be transferring her care there.
Okay. And did she tell you that she was starting a new medication?
Yes.
What did she tell you she was starting?
She said she was going to start Prozac.
And did she also tell you that what she was currently using for medication?
Yes.
And what was that?
The Ativan and the Benadryl.
And did she tell you that was for sleep as needed?
Yes.
And so you had put in place a plan on November 2nd to taper off the Ativan, but on November 22nd, she was still on the Ativan. Is that correct?
Yes.
And had she tapered off or reduced the dose, to your knowledge?
I don't have it documented exactly what dose she was taking on that date. She was just still taking the medicine.
Still taking it, okay. On that date, did Ms. Clancy deny suicidal and homicidal ideation?
Yes.
Did she show any signs of psychosis?
No.
Did she also tell you that she was going to be transferring her therapy care to that South Shore Perinatal Health Clinic?
Yes.
So basically at that point, the plan was for her to receive her mental health care at the South Shore Perinatal Clinic and no longer see you? Was that the plan? Okay. Was there also discussion of a return to work letter that day?
Yes.
And did she request that from you?
Yes.
And did you give her a return to work letter?
Yes.
And was that authorizing her to return to work immediately or on January 1st as the previous form had said?
I don't remember what date it was for her to return to work. I don't think it was immediate.
Did you then have a further appointment with Ms. Clancy on December 1st, 2022?
Yes.
And how is it that, she was planning on transferring care to the South Shore Perinatal Clinic on November 22nd, but then on December 1st, she has an appointment with you?
So patients can schedule their own appointments. I'm not involved in the scheduling. I can schedule an appointment if someone asks me to, but they can schedule it without my awareness. So she had scheduled it.
Okay. So she hadn't reached out to you in advance to ask about it. She just scheduled an appointment with you for December 1st, 2022. Is that correct?
Yes.
Okay. And in that appointment, did she tell you that she ended up not returning to work?
Yes.
And what was discussed at that appointment?
That she wasn't getting better.
And in what ways wasn't she getting better?
She had tried the Ativan taper, but without the Ativan, she was having a lot of difficulty sleeping. So she tried a few different medications, a few different medication combinations, but she was having trouble with them.
And did she tell you what types of medication she had tried?
Yes.
And what were those?
Trazodone 50 to 150 milligrams was minimal effect. Ativan and Benadryl combination was helpful. Then she added the Prozac 10 milligrams with the Ativan and Benadryl to help with the sleep, but she still had worse sleep, so that was stopped. Then she tried a combination of Remeron with Klonopin, but she felt disoriented, had rebound anxiety, and it was of minimal help. Then she tried Remeron and Seroquel, and that was prescribed, but she didn't take it.
And these medications that she was talking to you about, those weren't prescribed by you, correct?
Correct.
Did she tell you that those had been prescribed by her provider at South Shore Perinatal Clinic?
Yes.
And what is trazodone?
It is the category is an antidepressant, but the doses that we use are low, so it's really a sleep medicine.
And what is the lowest dose of trazodone?
50.
And what is the highest?
It can go very high, up to maybe 600.
Okay. So the 50 to 150 milligrams that Ms. Clancy told you she had taken, is that on the lower end of the dosage?
Yes, it's the commonly prescribed dose, again, because it's mostly used as a sleep medicine. So those are the normal ranges.
Okay. And Prozac, I think you had said earlier, was an SSRI?
Yes.
And that was a medication Ms. Clancy had told you she had taken in nursing school, correct?
Yes.
With no side effects then?
Yes.
And she told you on December 1st, 2022, that the Prozac had worsened her sleep?
Yes.
And then what is Remeron?
Remeron is mirtazapine.
And what's that?
It's another antidepressant.
And what is Klonopin?
It is a benzodiazepine like the Ativan.
So prescribing Remeron as an antidepressant and Klonopin as an anxiety medication, is that an unusual combination?
No.
And then she told you she had been prescribed Remeron and Seroquel but hadn't started that, correct?
So I think she had started the Remeron, but maybe hadn't started the Seroquel yet.
Okay. And did she also tell you that she was having some intrusive thoughts on the Remeron, so she was planning on stopping?
Yes.
Did she tell you what those intrusive thoughts were?
She said it was a feeling like I'm going to die.
Not a feeling that she wanted to kill herself, but a feeling like she was going to die.
Yes.
Did you ask her if she had suicidal ideation?
Yes.
What was her response?
So she denied having suicidal ideation, but she was feeling pretty badly. She said she was close to it, meaning close to having some suicidal thoughts, and that she was feeling very hopeless. But she didn't have any active thoughts of hurting herself, didn't have any intention of doing anything, didn't have any plans.
Did she also tell you, and this is a quote in the records on page 144, "I think it's my problem. I keep reaching out to different people and not sticking with the plan."
That's what I documented.
Okay. And did you discuss that with her, that concern that she kept reaching out to different people and wouldn't stick with the plan?
Yes, I advised that she have one person who is managing the medications.
And why is that important?
So that it's very clear what's happening.
And what is the importance, if any, of sticking with a plan, a mental health plan?
Well, the importance of sticking with a plan. Obviously, the psychiatrist comes up with a plan for very particular reasons. And so, sticking with the plan is advisable.
When you prescribe psychiatric medications, do those medications take effect immediately?
No.
How does that effect start to happen in a person?
Well, it depends which medicine. Some medicines do work very quickly, like the benzodiazepines, Ativan and Klonopin. But the medicines that prevent anxiety, the medicines that prevent depression, those do take a long time to actually kick in.
And why is that?
So the way that the medications interact with the brain, the serotonin receptors, the way that they change the neurotransmitters, it takes time for those changes to happen.
Okay. Now, did you also talk to Ms. Clancy about bipolar disorder that day?
Yes.
And why did you do that?
So it was mentioned because of the poor reaction she had had to some of her medications, the insomnia. So we discussed whether these side effects she was experiencing indicated she had bipolar disorder. But when that was assessed, it was not deemed that she had bipolar disorder.
And why was that?
Because she really didn't meet the criteria.
And what criteria didn't she meet?
So there's a number of different criteria for bipolar disorder, or specifically looking at mania, because she did have some symptoms of depression, but the other side is mania. So the most important one is euphoria. So actually 7 days of continued euphoria with very high energy levels. That's the most important one. But then in addition to that, you need some other things like potentially pressured speech, grandiosity, which is like a person feeling superhuman or godlike. You might see increased risk-taking behaviors. Usually those are significant risks, like somebody having affairs or using drugs, things that really negatively impact their life. The person might have a decreased need for sleep, which is not just insomnia, but it's truly not needing the sleep and having enormous amounts of energy otherwise.
What is pressured speech?
It means talking very fast, so fast that it's really hard to interrupt them.
And did you ask Ms. Clancy on December 1st questions that would potentially elicit whether or not she met that criteria?
Yes.
And did any of her responses to your questions indicate any instances of mania in her past or present?
No.
What was the plan going forward from that day?
So at this point, she was still seeing the doctors or the providers at South Shore, and so they were still managing her medications. So the plan was that she had an appointment with them tomorrow. She was considering taking the considering taking the Seroquel without the Remeron because she had had side effects with that, but that wasn't decided on. That was something to consider. And we also talked about starting a medicine called lamotrigine. I just gave her some information about the medicine, and we also talked about her going to a partial hospitalization program, which provides extra support for people who are really struggling.
Lamotrigine, is that Lamictal?
Yes.
And did you prescribe it to her that day or just discuss that option with her?
Just discussed on that day.
Why did you discuss that option with her?
Because it was clear that she had depressive symptoms and she was not tolerating some of the other antidepressants. So I thought that might be another option to explore.
And you also discussed with her a partial hospitalization program?
Yes.
And why did you do that?
Because she was really having a hard time. She had, mentioned those thoughts of feeling hopeless and the intrusive thoughts. So I referred her to a program that would provide extra support. It would be a program that she went to every single day, not hospitalized. She could still stay at home and be with her family, but that she would have all-day care every day for, as long as that was needed.
And what program was that you referred her to?
The HRI program.
What does HRI stand for?
It's a hospital. I'm not sure what it stands for.
And where is that program located?
It's in Massachusetts, I think Brookline.
And when you referred her, when you talked about that program with Ms. Clancy and referred her to that program, what was her response?
Well, I gave her the information for it. It's a program where the patient can call and schedule their intake appointment. So I gave her that information.
And was there any concern at that point? You had mentioned earlier that it's important to have, one provider prescribing medication, knowing what you're taking. You knew she was going to the South Shore Perinatal Program. Was there any concern about discussing medications with her, like Lamictal, on the first, when you knew she was seeing these other providers?
Well, she continued to see me in more of a supportive role, and I was just trying to help her, give her as much information that could potentially be helpful. So it was something for her to discuss with the other providers.
Did you ever reach out to South Shore or to get those records, or ask Lindsay for some type of waiver to get the South Shore records?
No, I didn't. And, the reason why is because she was very aware of what the medications were. She was very able to communicate what the different treatment decisions were. She was very medically sophisticated, so I didn't think it was necessary.
And you were aware she was a labor and delivery nurse, correct?
Yes.
So you were aware she was familiar with medications, and she was able to communicate with you on a level that's not a typical patient, correct?
Yes.
Did you next see her on December 16th, 2022?
Yes.
And did you make that appointment with her, or did she reach out as she did on the December 1st and make her own appointment?
I'm not sure.
Okay. And that appointment on December 16th, 2022, what did you discuss with her that day?
So she was still not feeling well. She said, I'm having a really rough time. She said she found something that was helpful for her sleep, Valium and quetiapine, which is Seroquel. She said it finally works, but feeling very depressed during the day, no motivation, had some SI, suicidal ideation, so she went to Mass General emergency room, declined inpatient. She was feeling hopeless, but didn't have any intent or suicidal plans.
So when she told you that she had had some suicidal ideation, did you ask her specifics about that?
Yes.
And what was her response?
So she described it as this hopelessness, like a fear of not getting better.
Did she have a plan on a plan to kill herself, or a plan of how to kill herself?
No.
And you mentioned she told you she went to Mass General Hospital Emergency Department because of these feelings. Is that correct?
Yes.
And did she tell you that they had offered her an inpatient program at McLean and she had turned them down?
Yes.
Did she tell you why she turned them down?
I don't remember.
Did she tell you about plans? Did she tell you what she was taking for medication at that point in the plans for medication?
She said she was taking a mixture of the Valium and the quetiapine, and there was a plan to increase the quetiapine, but currently she was taking 200 milligrams. And
did she also talk to you about the Women and Infants program in Rhode Island?
Yes.
And what did she tell you about that?
She said that she was referred and appointments were being scheduled.
And were you familiar with that program?
I've heard about it.
Okay. What type of program is it?
It's one of those partial hospitalization programs that I had mentioned, but it is focused on postpartum, so I thought that was a good fit.
Did she tell you during this appointment that she thought that her depression was related to the Seroquel?
Yes.
And did she tell you why she thought that?
She thought there was some coinciding of the timing in which she started the Seroquel and started feeling more depressed.
And did you note in the records that it was unclear if Seroquel was causing the depression as reported? She was more depressed the last visit before taking it?
Yes.
Can you just explain that, what your observations were?
Yeah, I wasn't sure if the Seroquel was making her worse because she did already seem depressed before she had started the Seroquel. So I wasn't sure. I thought it was possible, but.
What was the plan going forward from that appointment?
So the plan was for her to go to this Women in Infants program, and if she was having more suicidal thoughts, to go back to the emergency room.
And was she also planning to start Lamictal 25 milligrams daily?
Yes, at that moment, given how the depression was continuing and worsening, I did feel like after we had discussed the Lamictal numerous times that I did need to step in and prescribe that for her.
And you prescribed the 25 milligram daily dose for her?
Yes.
What's the lowest level of Lamictal that you would prescribe?
25.
And what's the highest?
So in psychiatry, typically 200, but I mean, it really can go up to 400 or 500.
And so again, you prescribed the lowest dose to start with, correct?
Yes.
And was she to continue with the Seroquel that she had been prescribed by the South Shore perinatal program?
Yes.
And what about Valium?
So I didn't make a recommendation on the Valium. I think there was a plan already in place on tapering it that I supported.
And did you do anything in terms of reaching out to her providers at South Shore Perinatal to let them know you were adding a prescription, or did you communicate with Ms. Clancy about letting her providers know?
I communicated with Lindsay about that, and she was so good at giving me all of these updates about what she did with them. I figured she would tell them when she next saw them.
And did she tell you that she would update them?
I believe so.
Was the next time you saw Ms. Clancy on January 6th, 2023?
Yes.
And how did that appointment come about?
So again, I don't often do the scheduling. I'm not sure exactly whether I had scheduled that or she had.
Did you learn during that appointment that Ms. Clancy had just been discharged from McLean Hospital?
Yes.
And what, if anything, did Ms. Clancy tell you about her current mental state and what had happened between your last appointment on December 16th and now this appointment on January 6th?
So she was continuing to feel depressed and attributing it to the Seroquel that she had been taking. So the idea was going to McLean so that she could be safely taken off of the Seroquel.
And was it at McLean, according to Ms. Clancy, that she had tapered off the Seroquel?
Yes.
And so on January 6th, did she tell you what she was prescribed at that time?
Yes.
And what was that?
Trazodone 100 milligrams, Ativan 1 milligram, and melatonin 5 milligrams.
Okay. And are these all low doses of these medications?
Yes.
Did you ask her if she had current suicidal ideation?
Yes.
And what did she say?
No.
Did you ask her if she had homicidal ideation?
Yes.
And what was her response?
No.
Did you observe any signs or symptoms of psychosis in her presentation, answers, or behavior?
No, I did not.
Did you ask her about whether she was having side effects from these medications, the Trazodone and the Ativan and the melatonin?
Yes.
What was her response?
So the only side effect she felt was that potentially when the Ativan would wear off, she would take it at night, and then in the morning it would wear off, and she would feel more anxious after it wore off.
And in terms of the Trazodone, did she say she had any side effects from the Trazodone?
No.
And melatonin, what is melatonin?
Melatonin is a chemical that the brain makes that tells us it's time to go to sleep. It's associated with the circadian rhythm. It's not a prescription, actually. It's a medicine that you can pick up in over the counter at the pharmacy.
And is it just to help regulate sleep?
Yes.
What was her mood, according to Ms. Clancy, on that date?
She was feeling numb.
Numb?
Numb.
Did that cause you any concern?
Yes.
And why is that?
Well, she still appeared quite depressed.
And in what way? Was that her affect?
It was, yes. Her affect was congruent, meaning it was the same as her mood.
So, just so we can understand, so if if I tell you I'm happy and I appear happy, is that congruent?
Yes.
And if I tell you I'm happy but I appear sad, is that incongruent?
Yes.
And is that important when evaluating a patient?
Yes.
And why is that?
Sometimes it's not congruent, and there could be all sorts of reasons why, but it's just something to pay attention to.
And so on this day, though her mood and her affect were congruent.
Yes.
Okay. And was there a plan formulated for that day, on that day?
Yes. So the plan on that day was to increase the trazodone to 150 milligrams. She had previously taken that dose and tolerated it well. She had just come off of the Seroquel at Mass General, at McLean. So we were still in the phase where we were monitoring to see if the depression might get better off of that medicine.
And is that why you didn't immediately prescribe a new antidepressant?
Yes.
Was she to continue the Ativan at 1 milligram per night and the melatonin at 5 milligrams per night?
Yes.
And I believe in this note for under condition, you wrote deteriorating.
Yes.
And why is that?
So it sounds like a very strong word. I will give some context that it's not my choice of a word. I have 3 options when I'm filling that out. I can say a patient is improving, unchanged, or deteriorating. So she wasn't improving and she wasn't really unchanged. She appeared a little bit worse than the last time I had seen her. So the best word is to say deteriorating.
Okay. Was there anything about her presentation or affect, things that she told you that led you to believe that she was in imminent danger of harming herself or someone else?
No, there wasn't. And we had, she was feeling depressed and we had a plan to address that.
Is there something you can do if you have a patient who you think is at risk of harming themselves or others?
Yes.
And what is that?
I could issue a Section 12, which would mandate that they be brought to a hospital for treatment, or at least for evaluation and then possible treatment.
And did you feel that was necessary at that time with Ms. Clancy?
No.
And when you're evaluating a patient, taking the history, looking at their current state, looking at what the answers they give you to the questions, are you reliant on the information that they give you?
Yes.
So if a patient withholds important information, is it hard to make a diagnosis or a plan?
Yes.
Was your next appointment with Ms. Clancy on January 9th, 2023?
Yes.
And what was discussed at that appointment?
So she said that the trazodone increase was helpful. She was still getting that rebound anxiety the day after she took the Ativan. The mood was okay, but she was feeling like she was still flat. She wasn't able to cry, but she said she was able to laugh a little bit, and hadn't been having recent thoughts of suicidal ideation.
Had not been?
Had not been.
And did you also ask her if she had any homicidal ideation?
Yes.
And what was her response?
No.
Did you notice any signs or symptoms of psychosis?
No, I did not.
Did you have a discussion with her about trying an antidepressant?
Yes, I did.
And what was that discussion?
So at this point, she had been off of the Seroquel for a couple weeks, and she wasn't getting better. So I thought that suggested the Seroquel might not have been what was causing depression, and it was depression. So that was what we needed to treat.
And what were your suggestions for treatment of the depression?
We considered some different options. We didn't pick a medicine on that date, but we considered amitriptyline and Wellbutrin.
And Wellbutrin was one of the medications she had taken when she was in nursing school, correct?
Yes.
And you discussed those medications on the 9th. Why wasn't a decision made that day?
Because we had made a different medication change because of that rebound anxiety with the Ativan. We decided to switch that to diazepam, which is Valium, and it has a longer half-life, meaning it's broken down by the body much more slowly, so you're less likely to get that rebound anxiety. And also the nice thing about the diazepam is it's easier to stop gradually. You can every week or every couple weeks, you can increase the dose by just 1 or 2 milligrams. So it's a lot easier to stop. So I felt that was a better alternative. And she also wanted to be off of the Ativan, so and be able to sleep without that kind of medicine.
And I don't think I asked you this before, but what is rebound anxiety?
It just means that when the medication that treats the anxiety gets out of the system, the anxiety comes back, and it comes back even worse.
And you explained it a little bit, but what is a half-life of a medication, and what does that mean in terms of the body processing it and how it affects you?
Yeah, so it's a little bit complicated, but it's basically the time it takes for half of the medicine to be broken down by the body.
And that tells you or indicates to you how long it lasts in the system?
Yes.
And so you were saying that Valium, the diazepam, the Valium, might avoid the rebound anxiety because it's slower to leave the body. Is that right?
Yes.
Did Ms. Clancy send you, after this appointment on the 9th, January 9th, did she send you emails on January 11th, 2023, asking you about your knowledge and thoughts on ketamine therapy and whether that would be a good option for her?
Yes, she did.
And what was your response to that? If you can't find it, I can bring it up to you.
I think I have it. So I mentioned that it's a great option, but it can be hard to get the insurance coverage for it. Usually you need to have demonstrated that you've tried 4 different antidepressants first, and so that it might be necessary to try another medicine first.
Okay. In that email where she was asking you about ketamine therapy, did she tell you that she was, did she say, I'm still feeling a very low mood, no motivation, just very depressed. This has been going on for months now, and I'm getting desperate for something that would work quickly to get me out of this depressed state. Do you remember that being part of the email?
Yes.
Had she indicated thoughts like that to you before, wanting something that would work quickly to help her feel better quickly?
I mean, she may have said that once or twice.
Do you know where, strike that, did you ever recommend ketamine therapy to you, or is this something she broached to you in this email for the first time?
It was something I had considered because at this point she was starting to be a bit treatment resistant, and ketamine is a treatment for treatment resistant depression. So it's a reasonable thought, but I didn't think we were at that point yet.
And you mentioned that insurance companies usually require you to try 4 antidepressants, is that correct?
Yes.
And when you say treatment resistant, is that someone who is in depression but the typical medications aren't working for them?
Yes.
And did you have an appointment with Ms. Clancy on January 16th, 2023?
Yes, I did.
And what was your interaction with Ms. Clancy on January 16th?
Her mood was still very low. She was still depressed. It was she was able to get out of bed and take care of her basics like hygiene and eating. Her concentration was fine, and she was doing what she needed to do to take care of her baby, though she subjectively felt like the bonding was forced with the baby.
She told you that the bonding felt forced with the baby?
Yes,
Did you ask her if she had suicidal or homicidal ideation?
I did.
And what was her response?
No.
Did she show any of the signs or symptoms of psychosis on that day?
No, she did not.
Did you have a discussion about a Valium taper?
Yes.
And why did you have that discussion? Who brought that up?
That was because she really did not want to have to take a benzodiazepine medication every day for sleep. So we discussed how to come off of that medication safely.
And that, again, is that like taper off to take a little bit less each time?
Yes.
And did she agree with that plan?
Yes.
Was a decision made at that point on which, if any, antidepressant to take?
No, we had not made a decision. Oh, sorry. At this point, we did. We did go ahead and decide to try the amitriptyline.
And what is amitriptyline?
So it is a tricyclic antidepressant.
What does that mean?
It's an older antidepressant that's been around for very many years. It helps treat insomnia and some pain, headache conditions as well.
And the dose that you prescribed, did you say it was 10 milligrams?
Trying to think of, or maybe it feels like, maybe you're thinking of things a little bit more slowly than you normally would.
And how often was she dwelling on suicide?
At what point?
At the point she told you that she had anxiety, insomnia, brain fog, crying inconsolably.
Objection, if we could have a date.
I think he's going to get to that. Good.
October 26th, heading into November 2nd. Do you recall, I'll rephrase it, do you recall going into the November month, meeting with her, and she told you that she had brain fog?
It was mentioned at some point. I
Okay.
don't see that on the 26th specifically.
All right, so let's talk about brain fog. Did you ask her what that meant? Because when you say subjective, that means that's her interpretation. That's in her head. She's telling you, right?
Yes.
As opposed to objective, which would be what people in general would think, right?
Yes.
So when she's telling you, in addition to the anxiety, in addition to the crying, in addition to the stress that she was undergoing, she was worrying about suicide, she talked about brain fog. So you must have asked her, what does that mean? Subjectively, what does that mean?
Subjectively means in the patient's, own opinion. That's what their experience is.
Okay, so she's the one that's inside her head, right?
Yes.
So what were the symptoms? What is it? When a patient tells you that they have brain fog, is that something you would consider as being a potential side effect of the medications that you would put her on?
It depends.
On what?
I mean, sometimes it could be, and sometimes it could be unrelated. It's a symptom of depression as well. So sometimes it's hard to tell what it's attributed to.
So at this point, heading into November, your answer was to prescribe more medication, 3 more drugs, right? You prescribed Ativan, or increased the Ativan. What was her load for Ativan at this point? Do you remember?
Sorry?
What was her milligrams, if that's right, or nanograms, whatever it is, on the Ativan, on the script that you had provided her?
Objection, if we could just have a date.
I think you said, no, if you can answer that, go ahead.
Which date are we referring to for the Ativan? Because there were. I'm sorry.
She already objected. He already said you can answer it. When did you increase her Ativan and to what level?
So she was prescribed Ativan 0.5 milligrams.
Right.
And then when I next saw her, she said it was a little bit helpful. So I said you could increase it and see if 1 milligram is more helpful.
Did she increase it?
Yes.
And when was the next time you saw her to talk to her on the television or on the computer?
Well, I saw her on the 26th, and then I saw her on the 31st. I'm sorry.
How was she on the 31st? Halloween, how
Sorry.
was she?
That's not my note. That's her therapy note.
Okay. So how about this November 2nd? Was that the next time you saw her?
I saw her on November 2nd.
And she told you that she was hesitant to use the medications, the Buspar and the hydroxyzine, right?
She said she was hesitant to try the Buspar.
She was scared of the drug. She was scared of the drugs, right?
She was afraid to take a medication.
She wasn't doctor shopping and asking you to give her drugs so she could get high. She was asking you for help. Isn't that right?
Yes.
And she was afraid to take the drugs and told you that she was afraid to take the drugs, right?
She told me she was afraid to take the Buspar.
Did you advise her or counsel her or give her therapy about that? Validations?
Yes.
And what did you tell her?
Well, I advised her of, the risks.
What were the risks?
Well, the risks of medicine, like we had said, sedation or dizziness.
Okay. How about interfering with sleep?
Buspar doesn't usually interfere with sleep.
Not usually? Did you ask her about any thoughts of suicide or being close to having thoughts of suicide?
Yes.
Did she indicate to you that she had any thoughts of suicide at all?
Not at that date.
Did she use those words, or is that a box that you checked off?
I don't remember her exact words, but we talked about suicide or, thoughts of hurting yourself.
Right. And there's a distinction between, in your records and the notation, between suicidal ideation and I quote, worrying about, thinking about suicide. Would you agree with that?
Yes.
And what did she mean when she told you, as her doctor, that she was worrying about, thinking about suicide?
You mean in the prior appointment?
I'm talking about a woman that's sitting in front of you on your television or your computer telling you that she was worried about thinking about suicide.
Well, on the 2nd, she didn't say that.
Okay. When was the next time that she told you that she was worried about or thinking about or suicidal ideation?
That was the December 1st visit.
Okay. So go back to the November 2nd visit. Would you agree with me that she, after you talked with her for that period, however long it was, that you then brought up 4 medications to her, recommending that they might be safer, and I quote, safer alternatives? Would you agree with that?
I see the word alternatives, not safer alternatives.
Do you remember talking to her about Remeron?
Yes.
Did you recommend that she take Remeron?
No.
Did you ever prescribe Remeron?
No.
And is that mirtazapine, as far as its generic name?
Yes.
And Remeron is an antidepressant, isn't that right?
Yes.
And you did not feel that that would be an appropriate medication for her to take at that time?
It was a very reasonable option, but we didn't decide to start it.
So is this a collaboration? In other words, you and the patient, you would both make a decision as to when to start a drug? Or is it your decision and advice to the patient?
Well, it's ultimately my decision, but the patient's thoughts about the matter are very important. At the end of the day, the patient has to go home and take it themselves. I'm not there to ensure that that is happening or not.
So you had a November 22nd appointment, right?
Yes.
And it was at that time that she told you that she had been to see South Shore Perinatal Clinic, right?
Yes.
And did she tell you why she was seeing someone from the South Shore Perinatal Clinic?
I think she told me that it was because they were exclusively focused on treating perinatal conditions.
Yeah, but so are you, right?
Not exclusively. I'm a general psychiatrist.
I see. And did she mention the name of any doctor or nurse practitioner that she was seeing at the South Shore Perinatal Clinic?
Yes.
Who'd she mention?
I think she said something about Julie.
Paul?
Yes.
Okay. And a woman by the name of Nurse Gelada?
I heard her name a little bit later, but
Okay.
yes.
Did she advise that, in fact, by script, she was using Ativan and Benadryl, and you told her to taper off the Ativan at that appointment, right? Had she tapered off the Ativan?
I think I had told her I gave her a prescribed taper prior to that appointment.
What does that mean? What does that mean, you gave her a prescribed taper?
So I told her that she should reduce her dose by 0.25 milligrams every 2 weeks until the medication was stopped.
Did she do that?
I mean, I don't believe that she completely stopped it, no.
No? You don't believe, or she didn't?
Well,
Trying to give the jury facts.
Yeah, she said she was taking Ativan, so no, she didn't completely stop it.
Had she tapered?
I'm not sure how much she had reduced the dose because I wasn't prescribing it again.
Right. So, did you know that she had been, or had she been, to any emergency wards between that period of time that you last saw her and when you were seeing her on this meeting?
I know she went to the ER, but I think it was after that.
Okay, which ER did she go to, do you know?
I think she went to Mass General.
Do you know why she went to the ER?
Because of depression.
So, was she treated at the ER? Did they make any, to your knowledge, as her doctor, make any recommendations?
I'm not sure what they told her, but they ultimately
Go ahead.
Discharged her. They didn't admit her.
Go ahead.
Sorry.
That's all right. Was she put on any medication?
Not from the ER.
When you looked at the records from South Shore Perinatal Clinic, what did they indicate about suicidal ideation, worrying about suicide, close to suicide, anything?
I didn't have access to those records.
You're going to keep your voice up so everybody can hear you. You what?
I did not have access to those records
None.
because we're a completely separate clinic.
Seriously? She's visiting with you as a patient and you can't access her medical records? Is what you're telling this jury?
I did not have access to them, no.
Could she have signed a release, a HIPAA form?
Yes, she could have.
And you could have got the records.
Yes.
But you didn't.
I did not feel like it was necessary because she provided all the relevant information about her treatment there.
How do you know? She's got a mental disease and she's suing you and she's on all this cocktail of drugs. How do you know that she is an accurate historian at this point in her life?
It felt very accurate when she was able to recall the names of the medicines, doses of the medicines, specific days. She provided a lot of incredibly detailed information. So it showed me she was capable of doing that.
So when you talked to her husband, Pat, how many times did you talk to her husband, Pat?
I think
The guy was living with her.
I think it was once.
And he came to your office, right? No, he didn't. He got on the television or on the computer screen, right?
Yes.
And when was that?
I think it was the December 16th visit.
So let's...
Mr. Reddington, before we get to that,
Okay.
probably a good spot to stop. We're going to take the morning recess, and then we'll come right back. Okay?
Court, all right. Sure, please close your notebooks, facing on your chairs.
You all set for the jury?
This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and the 18 jurors.
All right, thank you. Mr. Reddington.
If you would just please look at your medical records that you have in front of you, I believe, and just go back to the October 20th record, where you have, I believe it's called interval history.
I had trouble hearing the date. Can you repeat that?
Sure, October 20th. Sorry.
Okay.
So looking at the interview history, that's when that you decided to start Zoloft. It says a week ago, right?
That's when the patient started it, yes.
Okay. And she then increased the dose, and it says last night, right?
Yes.
And what was she telling you on the computer screen when you were talking to her? What did she say about increasing the dose of the Zoloft?
That she felt awful. She couldn't sleep. Had insomnia, which became worse when she increased the dose. She didn't want to eat. She was having diarrhea. Food felt really unappealing. She was more depressed on it, crying all day yesterday, which is not normal for her. She had some mental fog and was terrified to start something new.
Did she also tell you about her anxiety level?
Anxiety was really bad even before med. Now, hard to differentiate. Overnight, racing thoughts, paranoid of getting suicidal thoughts, something bad happening, doesn't want to be alone.
That must have given you concern that you had a pretty sick patient on your hands at that point, right?
I was concerned, yes.
So you gave her some therapy, did you?
I gave her some therapy in conjunction with discussing all of her symptoms and assessing her and managing medication.
Okay, and again, I apologize. You have to keep your voice up so people can hear you way down here. So when you say that you were talking about the symptoms, and what did you do? Just talk about the same thing that we had just gone over, the symptoms?
There were a number of them to discuss in more detail. That's the summary of them.
Okay. So did she discuss it in detail?
Yes.
Did she tell you that her symptomology at this point on October 20th was so bad that she had to have her mother come and stay with her?
Her mom was coming to provide support, yes.
She wasn't coming to provide support. She was coming to stay with them, to live with them, wasn't she?
Yes, I don't know for how long, but yes.
Did you bother to ask her? Why is her mother having to stay with them?
Because she needed some help.
Do you know how long her mother stayed with her?
I don't.
Do you know that she ended up sleeping in the basement?
I don't.
Do you know that she ended up sleeping with her mother?
I don't.
So you decided that you'd stop the Zoloft and you would monitor closely, right?
Yes.
What does that mean, you'd monitor closely?
I saw her the next day, so that's monitoring, an example of
Okay.
monitoring closely.
So this would be on October 21st that you saw her the next day, is that correct?
Yes.
Now, on the 20th, you made reference to the fact that you also recommended that she try fish oil and things of that nature, natural remedies.
Yes.
Okay. You also wanted to look into what's called Zulresso, Z-U-L-R-E-S-S-O.
Yes.
What's Zulresso?
It is a treatment for postpartum depression.
And when you say that you were looking into it, what did you do? Did you find out if it was available and if she could participate in the program?
I did some digging online to see where it is done and how to do it. I hadn't officially recommended it, so I had not started that for her. It's not really an easy medicine that I could just start.
It's not a what? I'm sorry.
Sorry, it's not a medication I could start on my own. It is it's infused through an IV in a hospital, so it's a bit difficult to coordinate.
It's a 60-hour infusion, right?
It's a long infusion, that sounds right.
And it's about 2.5 days of infusion, and it has to be under hospital circumstance, and the only hospital around here is in Rhode Island, right?
Yes.
And did you ever recommend that she do that?
It was something to consider. I couldn't make the official recommendation because that's not something I prescribe.
Why?
Because you can't pick that up at the pharmacy.
Well, no, obviously you have to go to a hospital setting and basically have an infusion through your veins for 60 hours or 2.5 days, but why didn't you look into it or recommend that she do that?
Well, I did look into it.
So what happened?
She ended up actually going to a partial hospitalization program at the hospital that does it. I don't believe the program is completed, but she went. And I advised her to discuss it with them because they have access to that medicine. I don't have access to it.
Of course not. Is this Women and Infants Hospital in Rhode Island that you're talking about?
Yes.
So when you looked at the medical records for Women and Infants Hospital, did they make reference to your inquiry for Zulresso?
I never received records from women and infants.
Did you ever look at them or even online?
Online?
Yeah, like online, like you do when you talk to patients.
No, I never had access to them.
Why?
It's similar to South Shore. It's a completely separate hospital that I don't have access to. I don't work there.
Well, of course you don't work there, but you're a doctor and you're treating a patient who's got medical records that you could access through a HIPAA release, right?
Yes.
Why didn't you do that?
Well, she didn't ultimately end up having any treatment there, so it didn't seem necessary.
She didn't end up having any treatment there, so it didn't seem necessary. You can't just walk into that place and say, hey, I'd like some Zulresso, can you?
I don't exactly know how it works.
And then again, on that date, which would be October 20, when the jurors are looking at the records, you checked off the boxes again on objective findings, mental status exam, appearance, speech, things of that nature, correct?
Yes.
Excuse me for 1 minute, Judge, jurors. So when she was telling you on that date that she was in quoting your records, paranoid of getting suicidal thoughts and something bad happening, doesn't want to be alone, what did she mean by that?
Well, those were a lot of her words.
Right. Isn't that a concern? If your patient is telling you she doesn't want to be alone, why didn't she want to be alone?
She was very anxious and had the feeling like something bad might happen.
Okay. Did her mother ultimately and dad come to stay with them?
Yes.
How long did they stay with them?
I don't know.
Did you when you talked to the mother and the father, did you say to them, what is she doing? How does she appear? Is she in bed all day? What did they tell you?
They never called my office, so I never spoke with them.
They never called your office?
They never called me or sent a message, so I did not have communication with them.
So that's their fault that they didn't call you, the doctor, I guess, right? So, do you think maybe it would be reasonable if you're the doctor and you're investigating your patient's symptomology that you might, when you know that the parents are staying with her, that you would make a phone call yourself?
It's not typical when you have an adult who is able to advocate for themselves to speak with their parents.
So while she is telling you about her symptomology and tearfulness and crying and unable to get up and anxiety and the medications and the mental illness that she had, you felt that she could advocate for herself?
Yes.
Okay, on the television, on the computer.
Yes.
The next time you saw her was on October 26th, is that correct? And you can pull up your record.
Yes.
Now, and if you look again at the interval history where you put down what's going on in the patient's life that time, this is when she indicated that she's back to where she felt that she was before Zoloft, which was not great, and that you guys were considering a new medication. Is that right?
Yes.
And then you started her on Ativan, as we talked about, right?
Yes.
And then you started her on the buspirone, right?
Well, she had already been started on the Ativan, and then we added the buspirone.
So my question was, you started her on buspirone, right?
Yes.
Okay. And also you added hydroxyline as needed, right?
Yes.
And you continued the Ativan, correct?
Yes.
Did you discuss side effects with her at that point?
Yes.
Did you also discuss starting Remeron or pregabalin?
Yes.
What did you tell her about Remeron and pregabalin?
I don't think I went into any detail about those medicines, just that those might be things to consider in the future.
And then you saw her on October 31st, right?
That was her. I think that was just a therapy appointment with a different provider.
Would that be Jennifer McAllister?
Yes.
So it's a different provider in the sense that she works for Astor, right?
Well, yes, it just wasn't myself.
Right. So on October 31st, they did a suicide assessment, or she did, right, McAllister?
I wasn't there.
Well, I know you weren't there, but these are medical records that have been introduced into evidence that the jury's going to have in the jury room.
Objection, is that a question?
No, good. Next question.
McAllister did a suicide assessment, apparently, right?
I'm sure she assessed.
No,
her
no, no. Look
suicide.
at the record, please,
Where do you see it? Sorry.
where it says suicide assessment. There's only 4 pages for October 31st. Well, actually, there would be 8 because it's 2 sides.
So that is the assessment that you go through. If somebody reports any thoughts of suicide, then you ask those questions, but you go into a lot more detail about them.
So here you have a patient who's already reported to you as a psychiatrist that she's got suicidal ideation, worried about suicide, worried about killing herself days before October 31st, and a suicide assessment was done by McAllister, right?
I wasn't there. You would have to ask her.
Well, maybe I will if she comes in. Why don't you tell me what the record shows? Did they do a suicide assessment? Did she check off the little boxes?
I'm looking for that section. It says that patient denies suicidal or homicidal ideation at this time.
Okay, so again, this is on October 31st, right?
Yes.
The patient, within a period of a couple of days and meetings with you, that McAllister has access to because the records are within your business, right?
It's not my business, but yes.
Has reported suicidal ideation and fear and dwelling about killing herself and afraid of those thoughts, right?
I just want to be absolutely clear.
Yes, the answer is yes.
Earlier, she had voiced those concerns.
Right. So as a result of voicing those concerns, is it your understanding that McAllister did not do any of the suicide assessment questions because Lindsay reported that she wasn't suicidal?
It appears that she asked about suicide.
Right, you already told us that. I'm asking you about, excuse me, she's not.
Hold on. Answer this question. Go
Thank
ahead.
you. I'm not asking you, you've told us 3 times now that she says she was not suicidal when she spoke to McAllister. I'm asking you about the suicide assessment for the 3rd time. You see it in front of you?
Yes.
Okay. Can you tell me, did Lindsay answer any of the questions that were asked over the 2 pages, possibly 3, of the suicide assessment? Yeah, 3, done by McAllister.
I don't see anything written here.
So was there a suicide assessment?
I don't know because I wasn't there. I don't know what.
And you don't know from
conversation
looking
was.
at the records, right?
From looking at the records, I don't see evidence of additional suicidal questions beyond asking if it was there or not.
So, the suicidal assessment, doctor, is in the medical records. It consumes almost 4 pages, does it not? Yes?
Yes.
Okay. And all of the questions, like asking, have you felt life is not worth living? Is death something you thought about recently? Are you dwelling on that? What leads up to the thoughts? What are the thoughts? All those questions, right? For 4 pages, right?
Yes.
And there is not one notation indicating that that test was ever administered to her on October 31st, correct?
But it looks like it was asked in other ways.
Yeah, okay. November 2nd. Oh, it was asked in other ways? Is that what the little checkbox where it says denies suicidal ideation?
Can I read something that she
You
wrote
have
down?
indicated repeatedly that she denied suicidal ideation, right?
Yes.
Okay. The suicidal assessment was not administered, according to the record that's in front of you, by McAllister, yes?
The additional suicidal assessment, yes.
November 2nd. Oh, by the way, as a psychiatrist, not a psychologist, you have the ability to prescribe medication, obviously, right?
Yes.
And that's what we talked about, the DEA number and all of that, correct, which you had for about a month, other than when you were a resident, right?
Yes.
So you're prescribing these SSRIs and antipsychotics and antitropics or whatever they are, and it's important as to the metabolism of your patient with those drugs, isn't it?
Yes.
Okay, keep your voice up. What does metabolism mean?
The body breaking down the medication.
So how is it that you can determine how the body of your patient is breaking down the medication that is in their brain and they're complaining about all of these symptoms? How, as a doctor, do you determine how the body's breaking it down?
We don't typically have any specific testing that we do to understand that.
How about a blood test?
It's not done for that.
It's not done for that, meaning a blood test is not done to determine the metabolism of your patient, of your medications?
Are you referring to genetic testing?
No, I'm asking about the metabolism. I'm not talking about genetics. I'm talking about the metabolism of the SSRIs in her body.
Okay.
You can tell that metabolism rate through blood testing, right?
Not in the way that you're describing.
Okay, what way would it be?
There is genetic testing that can give information about metabolism.
Like what?
It can talk about different enzymes that a person might have to suggest a It provides information about the enzymes that a person might have the genes for.
Okay, so it provides the enzymes that a person might have the genes for. Forgive me, I'm having difficulty with that. What does that mean?
It's a little complicated.
Yeah, you don't expect a patient that's going through what she was going through to understand that, would you?
No,
Did you guys do the enzyme test?
they are not typically done.
Why?
Because, again, it's genetics.
Does
and-
insurance cover it?
Objection, just in the middle of answering.
Finish that answer, and I'll allow a follow-up.
So it's not as simple as testing for an enzyme or not. You can test someone's genome, like we have the ability to test the entire human genome now, but which is great, but the clinical use of that is not there yet. So while we can test these things, it does not yield meaningful clinical information, so it's not commonly done.
What is the Cytopro P4-50 system?
That's one of the enzymes that I'm talking about.
So the Cytopro P450 system talks about and tests for the breakdown of psychiatric meds in the blood, right?
It's not in the way that you're describing. It doesn't
All I'm
tell you
describing
what
it is that it's a
Hold on,
test.
again, one at a time. Finish the answer, then you can ask follow-up.
It just, yes, this is a test that is done, but it doesn't tell you what medications a patient will do better on. It's not useful in that way.
So what's it useful for?
I mean, I don't find it terribly useful.
How long has the Cytopro P450 system been in use in your field?
Sorry?
How long has the Cytopro P450 system been in use in your field, psychiatry?
Well, it's an enzyme in the body.
Well, I know what it is. I'm asking you about the system, the testing. How long have they been using that?
The genetic testing,
Yeah,
maybe
whatever
a few
it is.
years. It's very new,
Very new. Does insurance cover it?
sometimes.
Sometimes. So it is nevertheless a legitimate test to determine the breakdown of psychiatric meds in a patient's blood, correct?
It exists, yes.
It exists. Well, it exists, but you didn't use it, right?
It would not have made a difference
In what? In your opinion?
in her treatment.
Because you go by the checks in the checkbox and what she self-reports, right?
No, not just the checks in the checkbox.
Oh. In any event, tell me about the thyroid.
The
Tell me
thyroid,
about the thyroid.
it's an organ in the human body that regulates hormones.
And what, if any, import and impact do thyroid levels have in your evaluation of a woman who is in the throes of postpartum depression?
They don't.
What is the purpose of a test to determine the thyroid levels?
Well, you can test something like the TSH.
Well, I don't know what TSH is, I'm sorry. What is a TSH?
Thyroid stimulating hormone.
Okay, thank you.
That's something that can be tested, typically by maybe a PCP, primary care, or endocrinologist if they have concerns about someone's thyroid function.
Were you aware of a study that was a major study that was peer-reviewed? What does peer-reviewed mean in your business?
That it was reviewed by other researchers in similar fields.
And the report or the article or whatever it may be has to be approved by the peers that are reviewing it before it can be published, right?
Yes.
And you'd agree with me that in the medical field, it's a big deal to have publishing articles on your resume, right?
Yes.
And how many articles have you published about postpartum depression, postpartum psychosis, anything?
I have published something, but it's not a full article. It's just a small thing.
Okay. Are you aware of the Psychiatry magazine article dealing with, in 2021, thyroid function in postpartum psychosis, an exploratory study? Have you ever heard of anything about that, let alone read an article about it?
No.
Are you aware that there are studies that have compared thyroid function between psychosis with postpartum onset, PPO, psychosis without postpartum onset, PWPO, and normal postpartum? You aware of that?
No.
Well, you're supposed to be an expert, or you specialize, or you have an interest in treating women that have suffered from postpartum, correct?
Yes.
Have you written any articles at all about postpartum? Depression, anxiety, psychosis?
No, I'm not a researcher. I'm a clinician.
Have you read any of the articles, such as thyroid function in postpartum psychosis?
I've read many articles. There are thousands. I have not read that specific article.
Thousands? Thousands of articles on postpartum psychosis and the thyroid?
No, not on that specific topic.
So, when the Astor doctors are treating a person like Lindsay, it's your testimony to this jury that testing, whether it's blood testing or whether it's the Cytopro P4 testing, is not necessary because Jennifer Tufts doesn't think it's necessary, right?
It does not yield information that would influence treatment.
Really? So if there was elevation in the thyroid, that wouldn't impact on your treatment at all, your evaluation, your investigation?
Sorry, I thought you had mentioned the cytochrome issue. Are we talking about that one, or are we talking about the thyroid?
We're talking about the thyroid.
Okay.
Yeah. So if there were tests that revealed elevation in the thyroid level, is it your testimony that you wouldn't care?
If I somehow found out that a patient had elevated thyroid levels, I would advise them to talk to their primary care or maybe get an endocrinologist to discuss it.
Did you ever recommend that Lindsay get an endocrinologist?
No,
And the reason, the answer is no. And you basically did not have any information that you could use to even realize that there might have been a thyroid issue with this woman that was postpartum, right? Because you didn't do any blood tests.
There was no clinical reason to obtain a blood test.
All right. So you continue on with your meetings by the computer, correct?
Yes.
November 2nd. You can get November 2nd out. You got it?
November 22nd?
No, it looks like November 2nd. I apologize. That's what I'm looking at. Tufts, Jennifer, MD, Clancy, Lindsay. Follow-up note, November 2nd.
Yes.
Okay. And you're still diagnosing her with generalized anxiety disorder, GAD, right?
Yes.
You add in there an adjustment disorder with depressed mood, I guess because of what she had been telling you, right?
Yes.
Okay. Looking at the psychiatric condition, you note that it's improving, right?
Yes.
And then you determine that you will decrease the Ativan to 0.75 milligrams for 2 weeks, and then decrease it to 0.5 milligrams for 2 weeks, and consider alternatives for sleep anxiety. Is that correct?
Yes.
And then you note if she's having urges to harm herself or others, to go to the nearest emergency room and call 911 and things of that nature, correct?
Yes.
So is that a form that you basically press a button and it because it seems to be kind of like a generic advice. Call 911 if you're feeling suicidal and things of that nature.
Well, that's advice that we provide for every single patient.
Okay. And then you note that half the encounter was on counseling or coordination of care on November 2nd, right?
Yes, that's a typical statement. It's just a part of documentation that doctors use.
All right. Now, on November 2nd, you were suggesting the 4 drugs that she would start would be Remeron, Trazodone, Pregabalin, and hydroxyzine, right?
Those were just things we were considering.
Oh.
I wasn't starting all of those medicines.
I see. On November 22nd, now that would be almost 3 weeks later, right? You saw her, right? And did you ask her about whether or not she was still having suicidal thoughts or worrying about suicidal thoughts, for example? Did you ask her that?
Yes,
And how do you know that? Because the box is checked?
it's written in my note.
What does it say?
Patient denies SI.
Okay. What did you ask her about that?
I don't remember the exact words, but I know that I asked about that.
Did you ask her about how things were going at home with her mother and father staying there?
That I don't remember. I didn't document how her parents were doing.
Okay. Well, I don't really care about how her parents were doing. I'm asking about whether or not you asked her how it was working out while her parents were there helping out. If you did, fine. If you didn't, that's fine too.
I don't think that I did. And this
Okay.
appointment should.
Okay. That's all. That's fine. December 1st was the next appointment, correct? And you can look at the interval history.
Yes.
Now, on that December 1st appointment, this is after she had transferred to South Shore.
Yes.
She disclosed to you that she had been seeing South Shore, right?
Yes.
We already talked about the fact that you never got the records from South Shore, so you don't know, other than what Lindsay reported to you, what medications she was on, right?
Right. I knew what she was telling me.
Right, and she told you that she was doing the Ativan taper, right?
Well, she said she had tried doing that, but that then she was having more sleep.
Having difficulty sleeping is what she indicated to you, right?
Yes.
And she tried other meds that you had suggested, but stated that she was having difficulty with those meds, including Trazodone, right?
Well, the Trazodone she didn't have a problem with. It just didn't seem like it was particularly helpful.
Right. Did you prescribe the Trazodone or somebody else?
This was somebody else.
So, do you know what the milligrams were that she was on?
It says she tried between 50 and 150 milligrams.
All right. Now, did she at some point try Remeron?
She said that she did.
Did you suggest in your discussions that she try Remeron?
No, I did not.
Did she indicate to you that she had rebound anxiety and intrusive thoughts, that she was going to die? Do you recall that?
Well, she said worse depression and intrusive thoughts.
Okay. Did she tell you what the intrusive thoughts were?
It was the feeling like I'm going to die.
Did she then have a script for Prozac, 10 milligrams?
That's what she said.
And she said that she couldn't sleep and had worse sleep, so that had to be stopped, right?
Yes.
She had, then she was on Klonopin, right?
Yes.
And what is Klonopin?
It's a benzodiazepine.
And on December 1st is when she told you, again, that she was close to having suicidal ideation, feeling hopeless. Do you recall that?
Yes.
Now, on the interval history, on that date, you indicated that she can't sleep, she's panicking, she had worse depression, intrusive thoughts, she was numb, nothing mattered, I feel like I'm going to die. Denies suicidal ideation, but, quote, yesterday, close to it, feeling hopeless. Did you give her therapy and validations after she told you that?
I did.
What did you do? You got a woman that's telling you that she's hopeless. She doesn't care if she dies. She can't sleep. What did you do to validate on your therapy?
I told her that this was something that we could address, that there was hope, that there were treatments, and there are different types of treatment programs that are more supportive, like partial hospitalization programs. So she knew that she still had options and a reason to hope.
Did you ever suggest to her that maybe you ought to come in to see me rather than talk on the computer?
Talking with her over the video did not seem like an issue. It didn't seem like there was anything that I was missing or that there was any need to see her in person.
Now, you'd agree with me that in December of 2022, COVID was all done, right?
It wasn't completely all done.
Were you still nervous about dealing with people and wearing masks and stuff, or were you able to sit down and talk to somebody face to face?
We were definitely feeling more comfortable about being face to face with people, but I think, it was still something that we thought about.
You discussed trying Seroquel with her at that point, right?
I didn't really discuss it. She had told me that was something that she had discussed with her other provider.
So, looking at your notes, does it say also discussed trying Seroquel alone tonight? Did your notes say that?
It says yes,
What is
but
that?
I wasn't making a recommendation about the Seroquel. It was just a medicine I was providing her more information on.
So you were telling her about the Seroquel? You're providing information?
Yes, we were talking about the Seroquel
Right. Why?
because her provider had recommended that she start it.
What is Seroquel? You also discussed with her the possibility of undiagnosed bipolar disorder, did you not?
It was discussed.
And undiagnosed bipolar disorder was, in your opinion, as a result of, not a reaction, but extreme reaction to the SSRIs, right?
Not as a result of the SSRIs, but that
Does your note say, and I quote, also discussed possibility of undiagnosed bipolar disorder given extreme reaction to SSRIs and insomnia, period. Does it say that?
Yes.
Those are your notes, right?
Yes, the way you were saying it made it sound a little bit different before, but that's exactly what I wrote.
I read it directly from your note, right? How did I make it sound different?
I don't know. It sounded different the first time you said it than the second.
So did she have bipolar?
No.
Did you make that decision that night? That day?
I assessed that with her pretty much every time that I saw her, and she never had mania.
What about mood stabilizer like Lamictal? Did you discuss that with her?
Yes.
What is Lamictal?
It's an anticonvulsant, but it's used in treating mood disorders.
So what was the end result of your meeting with her on December 1st? What did you guys do? Did you give her any recommendations, advice, anything?
Yeah, well, so at this time I was not prescribing her medications, but I was still concerned, not concerned enough that she was at imminent risk of hurting herself or anybody else, given what she said. But we had a plan for her to pursue a partial hospitalization program.
Where was that?
Well, the one that I had recommended was HRI.
What is that, HRI?
It's a hospital in Brookline.
And did she ultimately go to another hospital?
She ultimately went to the Women and Infants Hospital for 1 day.
And those are the records that you did get, right?
Correct.
Okay. And you decided that she did not have bipolar disorder because, in your opinion, she did not meet, and I quote, the criteria, right? And that would be the criteria in the DSM, right?
Yes.
And the DSM, of course, is the Diagnostic Statistical Manual, Roman numeral 5R, meaning text revision, right?
Yes.
Is that what you were using back then? Would be this thing here, DSM-5, TR? This is DSM, right? It's like a cookbook, right?
It's more of a guideline that we use to help us in our treatment, but it's not the psychiatry Bible that people sometimes think that it is.
Right. Hypomanic bipolar disorder. How many days does that require under the DSM?
A hypomanic episode lasts for at least 4 days.
And is that per the DSM?
Yes.
Remember on Friday you said that the most important criteria is 7 days with continued high energy levels?
Yes.
So is it 7 days or is it 4 days? And who says?
Well, mania is 7 days. Hypomania is 4.
Discussed again, Monday does occur on December 1st, and that would be the Lamont sheet, right?
Yes.
And you know in your records that she indicated that she was really struggling, and it was as a result of that you recommended that hospital program, correct? Would you agree that she had, in your opinion, a severe mental disturbance at that point that was manifesting itself?
She had a maybe moderate heading towards severe.
Moderate heading towards severe mental issue, okay. You'd agree with me that she had increased anxiety, right?
Yes.
She had very, very increased depression, right?
Well, she did. She said.
Okay, so as you answer
something
yes,
wrong.
can you just answer yes or no?
I'm sorry, I was just trying to check the record.
Okay, you can check the record all you want, but if I ask you a question respectfully, can you just not go on and ramble? Answer yes or no, that's all.
It's sometimes impossible to do that.
All right, you tell me.
Here, if you can't answer yes or no, just say you can't answer yes or no. If you can answer yes or no, answer yes or no. That's how we do it, all right?
Okay.
Thank you. Now, mental issues like anxiety that was diagnosed, the depression that was diagnosed, and the fact that she indicated yet again that she was close to suicidal ideation, quote, worried about suicidal thoughts, but you indicated that she wasn't suffering from suicidal ideation on that date. Is that fair?
She denied it.
But she told you that she was worried about suicidal ideation and having suicidal thoughts, right?
Well, this was the time she said she was worried that she was close to having suicidal thoughts.
So did you ask her what does that mean? Does that mean that she's standing at the edge of the stairs and she's thinking about falling down the stairs, or what? What does that mean? I'm close to suicidal ideation.
So I asked about that, and that's when she said she described it further as using the word hopeless.
So did you prescribe the lamotrigine on that occasion or no?
No.
On December 16th, that's the next appointment she had, right?
Yes.
That'd be 2 weeks later, right?
Yes.
She was still not well, correct? She told you she was having a really rough time.
She was sleeping, but she was still feeling very broken.
In your notes, does it say that she was having a really rough time?
Yes.
So when I asked you If your notes reflected that she said she was having a really rough time, why do you feel compelled to say she was sleeping?
Objection.
It's an important detail.
Yeah, I guess. How about the rough time? What did that mean? What were the symptoms of having a really rough time for this kid? Yeah, I'd like you to answer that.
So finally words, referring to the valine-nicotiapine, but very depressed during the day, no motivation, some SI. Do you want me to continue?
Sure.
Went to MGH emergency room for SI, declined inpatient, feeling hopeless, no intent or plan, and feels like depression related to Seroquel.
Okay. Now that's the question on Friday that, well, strike that. So what was the SI, suicidal ideation?
Yes.
And can you read that back to me again? What did she say about SI?
So that when she went to the hospital, she went because she had no motivation, some SI.
Some SI meaning that she had some suicidal ideation, right? Yes?
In her words, yes.
Yeah, in her words. As opposed to thinking about having suicidal ideation or worrying about suicidal ideation. She actually indicated that she had suicidal ideation, right?
Yes or no?
Well, it's in your notes that she said that, right? Yes?
What is in my note?
Do you understand my question?
I'm a little bit confused right now. Can you repeat what your question is?
Sure, of course. We've spent some time talking about thinking about suicidal ideation, worrying about suicidal ideation. Now, saying she had suicidal ideation, right?
She said it, yes.
Yeah. Well, this is the only source of information that you're getting, apparently, is what she's telling you, right?
Yes.
So what suicidal ideation did she have? Was she thinking of cutting her throat? Was she thinking of throwing herself off a building, running out in front of a car? What?
No.
What was she thinking of?
So I asked her those important follow-up questions. And
Like
that's, so what do you mean when you say I'm feeling suicidal?
Okay.
And that's when she said, it means I'm feeling hopeless. And then I asked you, do you have intention of hurting yourself? Do you have a plan for hurting yourself? And she denied those.
And that's where you left it?
I'm sure more was said, but that's the most important part of that clinical encounter.
And did you give a therapy by the computer on that date, too?
Yes.
What did you do for therapy about her suicidal ideation and saying she wanted to kill herself?
Well, we explored what that meant, and what to do if you're feeling that way.
To do what? Call 911?
To go to the emergency room.
Did you discuss prescribing Seroquel to her, or was she getting Seroquel? Did Seroquel enter into your discussion at all?
We talked about it. I was not prescribing it for her.
What is Seroquel?
That's an antipsychotic.
So, at the conclusion of your meeting on December 16th, basically what you took away is that she had now increased to suicidal ideation, was feeling hopeless, all the rest of the things that we've talked about, and then she what, just moved on, went home?
Well, she was assessed in the emergency room and was not admitted, and I assessed her on that day again, and while she was certainly struggling, she did not require hospitalization at that moment. So she was planning on going to the infants program, and I supported that.
Did you know that around that time she confessed to her husband that she was having now thoughts of harming the children?
No.
Would that have been something you were concerned about?
If If I heard that, I would have been very concerned.
You would have called DCF, right?
I might have.
And when you spoke to Pat, did you ever ask him what his observations were of her spiraling into November and December? Not that one time that he stuck his face on the computer and talked to you. Did you ever talk to him?
He never called me again. Or he never called at all. I never spoke with him again.
So he is a husband of a woman, just had a baby, who was postpartum with all of these symptoms that we talked about, all of the drugs that you were prescribing, and that she was dealing with trying to get help. You never talked to her husband about what he observed? Because he didn't call you?
Well, we did speak on that visit,
Which visit?
the 16th. Or I think that that's the one that he was at.
You think it was? It's not noted in your records?
It's not noted, but I remember some of what we talked about, and so in reading that record, it seems like that's the likely one that he was at.
December 16th, on your objective findings, you note that her mood was depressed, right?
Yes.
What does that mean? Did she just say, I'm depressed, or did she give you symptoms? I mean, you checked the little box.
Yeah, I mean, she's saying that she's depressed.
Okay, so you're the doctor. You checked the little box. What did your patient tell you about her symptoms that she was depressed on that date? Was she crying? Was she able to get out of bed? Was she worshiping at the porcelain god? What was going on in her life?
She said she was having a really tough time.
Her affect was flat, right?
Yes.
And again, depressed. You check it off twice. One under mood and one under affect, right?
Yes.
And then next page it says recent lab work. That wouldn't be blood testing, would it? I mean, does Asta do blood testing?
We don't have a phlebotomist or a lab, no.
Well, why does it say recent lab work typed into your form where you check off the little boxes?
That's something that auto-populates. It's a template that...
It's a what?
Many different... It's a template. The whole note is something that psychiatrists or probably all across the country use.
Probably. You can't diagnose someone's illness by a template, though, can you?
No.
You filled in, no lab results were found, right?
There were none in the computer, yes. I didn't type that in, though.
So who typed it in?
It was auto-populated.
So on the next page where it talks about symptom goals, treatment goals, I'm sorry, symptom reduction and improve functioning. What does that mean?
Symptom reduction is to have fewer mental health symptoms, and improved functioning means, improved, day-to-day life functioning, things that she's doing in her daily life.
Really? Did you tell her all that? You get a young woman that's obviously mentally ill, very sick. She's deteriorating, whether you like that word or it's automatically imported. What, on that date, did you do? Never mind all those words you just said. What did you tell her on the television or the computer?
I told her to go to the partial hospitalization program, and if she was having more suicidal thoughts again, or felt like she was at risk of hurting herself or anybody else, that she should go immediately to the emergency room.
How long did that meeting take?
Probably about 30 minutes.
And was that the therapy that you provided, telling her to go to the emergency room?
I mean, that was probably a component.
So the plan, excuse me, on December 16th was to follow up with women and infants, right?
Yes.
Did she?
Yes.
Do you know when?
I
What does that
exactly
mean?
the day,
You
shortly
know?
after.
Then you were considering a brexanolone or brexanolone infusion, right?
That's the Zolbrexo.
That's the same thing in Rhode Island.
Yeah.
Okay. And that didn't go anywhere, right? That's the end of that. It says start Lamictal, 25 milligrams daily, right?
Yes.
Continue Seroquel, right? What was the milligram for the Seroquel up to at this point?
Well, she had told me it was 200.
Well,
That
was
was,
it? Was it?
I did not write that prescription, so that's what her provider had prescribed her.
Okay, so you can ask somebody to show me the pill bottle. You can ask somebody to show me the CVS receipt. You can ask somebody that you can call to verify, right?
I could.
Yeah. But anyway, she said that she was on Seroquel 200 milligrams, right, and had stopped with the Valium, right?
Yes.
And then you go on with that form thing saying if you have urges to harm yourself or others, you got to call 911, crisis hotlines, and everything else, right? That's the next two paragraphs that are in that report, right?
Yes.
Was her mother and father still staying with her on December 16th, if you know, with Pat and the kids?
I'm not sure.
Did you ever ask anybody other than her how she was doing?
I asked her husband when he was at the appointment.
Yeah, that's the other appointment, though. How about now? We're talking December 16th into the month of December. Did you ever ask anyone how she was doing?
I think he was at that visit.
You think he was at the visit? How did he tell? What did he say to you about how she was doing?
He said she wasn't doing well.
She's got an objection, Judge.
Objection.
Go ahead.
He said she wasn't doing well.
Anything else?
Yeah. He felt that it might have been, his opinion was that it was related to when she started the Seroquel.
And he basically said you guys are turning her into a zombie, right?
Objection.
Were those his words?
I don't have that written. He may have said that.
Does that kind of hit you, though? You might remember that. You might have been, as some people worry about suicide, you might be thinking in your brain that he did say you're turning her into a zombie. Possible.
It's very possible.
Okay. Excuse me. Next meeting after the December 16th, was it? Was it December 16th? Is that what we were just on?
Yes.
Okay. The next meeting was January 6th?
Yes.
Okay. And how does this happen? Does the patient call? I know you don't set up these appointments. Somebody has to deal with somebody in administration or whatever. But do you, like on December 16th, say to Lindsay, call me or set up an appointment for January 6th, or do they have to do it themselves?
So at the end of an appointment, I typically will schedule their next appointment.
So did you schedule January 6th?
I think that one she scheduled herself.
Yeah, that was the day after she got out of McLean, right?
Yeah, usually the hospital coordinates the discharge appointment.
Well, if I tell you that, in fact, the hospital told her to set up the appointment, and that within an hour, she set up the appointment. Is that in your notes?
It's not in my notes. No.
Do you remember that? That was a pretty big deal when she was in McLean, locked wards for 4.5 days, right?
Yes.
And she's your patient, and she's really gone downhill bad, right?
She wasn't doing well.
And she admitted herself to the locked wards at McLean, right?
Yes.
And what was the diagnosis at McLean?
I believe they diagnosed her with major depression.
Did they recommend any medication?
They took her off of the Seroquel.
They took her
Off of it.
off. Okay. So, did you look at the McLean records?
Yes, definitely.
And those were imported easily because you're part of the same structure or whatever?
No, but after someone is hospitalized, the hospital usually faxes it to their doctor.
All right, so if I tell you that the McLean records are really pretty voluminous, that's not what they fax. They fax you like a 2-page discharge summary, right?
Yes.
You didn't get that by fax, right?
No.
So what did McLean tell you? Look in your notes.
Which part do you want me to read?
Did you ever have her sign a release from McLean? Did you ever get access to the McLean records?
I have access to the discharge summary.
Okay, so put the discharge summary aside because that's what they faxed you, a couple of pages. What about the records?
No, but that's typically not.
No, never mind typically. The answer is no. You never got the records, right?
A discharge summary is a record.
Did you talk to the doctor that discharged her?
No, no one called me.
No what?
No one called me. I wasn't notified of the hospitalization until she was discharged.
So you just sit there behind your computer and wait for people, Patrick, wait for the doctor from McLean, wait for the sick person who's the patient to call you? And if these people don't call you, it doesn't exist apparently, right?
No, not exactly. I had no way of knowing she was even at McLean.
Well, you did once she got discharged, right?
Yeah, but that was after the fact.
Right. So did you care why she was in McLean?
Of course.
And why was she in McLean?
She was depressed.
And what was the, does your record indicate that she was discharged yesterday under interval history?
Yes.
And discharged from where?
Well, I said NGH.
Is that Mass General Hospital?
Yes.
And she was currently on trazodone?
Yes.
She indicated that the goal was to come off Seroquel,
Yes.
and she described herself as still being very numb.
Yes.
She couldn't sleep, right?
That's not entirely true.
Am I lying? I'm reading the medical records here. Sleep, taking Ativan and trazodone, slept 5 hours broken, wondering about increasing trazodone and switching to Valium. What does that mean?
Well, it means she was having trouble sleeping. It wasn't that she wasn't sleeping.
Ah, I see. Okay. So was the trazodone increased at that point?
Yes. Yes.
How about on January 9th? Did you see her through the computer or whatever then?
Yes.
And did you prescribe medication to her on that date?
Yes.
And was that diazepam?
Yes.
14 count, 1 milligram? No, I'm sorry. 14 count, 5 milligram.
That sounds right.
Okay. Did you also, on January 12th, 3 days after January 9th meeting, prescribe additional medication to her?
I'm not sure. I don't have a record from January 12th.
Do you recall on January 12th that, in fact, you prescribed trazodone 150 milligrams, 30 count?
Yes.
3 days later, or a couple of days later, January 16th, do you recall prescribing amitriptyline?
Yes.
What is amitriptyline?
Tricyclic antidepressant.
What does a tricyclic antidepressant mean?
Well, it's an older antidepressant. It's called a tricyclic because it has 3 rings. If you look at the chemical itself, like a tricycle. But it's an older but efficacious medicine for depression and anxiety as well as insomnia.
On January 16th, look at your interval history. Did she indicate to you that her mood was very low, no motivation,
Yes.
numb,
Yes.
able to force herself out of bed, taking care of basics, eating, concentration fine, caring for baby, bonding feels forced? Is that what she told you?
Yes.
Through the computer, right? What did that tell you? Were you concerned about this woman postpartum well within the year from the CDC at that point with these symptoms that she's telling you about?
I was concerned that she was depressed.
And in all of the times that you spoke to her, you'd agree with me that she appeared to be honest and forthright, telling you what she felt, right?
That's what I thought she was, yes.
Do you have any reason to think that she was lying to you?
No.
Diazepam taper on January 16th, 5 milligrams last 2 nights, slept for 4 hours, and then a light sleep, maybe 2 hours, stretches. Did she express that she was still having concerns about side effects from medications?
Not at that point.
So what does ROS mean under interval history that we're looking at?
A few of symptoms.
Okay. And then it says patient denies SIHI, that'd be suicidal ideation, homicidal ideation, correct?
Yes.
Denies other questions or concerns, and you recommend a low dose of amitriptyline for depression, correct?
Yes.
Patient agrees with the treatment, and you guys were also going to explore ketamine treatment. Is that right? Esketamine.
Yes.
Now,
Patients telling you what to do and how to handle them?
No.
Were you alone responsible for the evaluation, diagnosis, and treatment of your patients?
For the most part, but if I had questions or, needed to talk it through, I had help.
And approximately how many patients did you treat during those 4 years?
Thousands?
And those were all psychiatric patients, correct?
Yes.
You said approximately 50 of those patients were patients dealing with postpartum depression or some postpartum issues. Is that correct?
Yes.
You also said you had some specialized or specific training in that area. Can you describe that for us?
Yes, I did a specialized elective with a specifically perinatal psychiatrist where I worked in an obstetrics clinic and I saw patients who were pregnant and postpartum.
And how long was that clinic for?
It was for about a year.
And so for a year, you were evaluating and diagnosing and treating women with postpartum issues?
Yes.
And that's separate and apart from your residency?
It's a part of the residency. It's an elective.
So for 1 year out of the 4, that was specifically designated to postpartum issues?
Yes. It wasn't every single day, but it was continuing the same patients for about a year.
So you would follow those same patients throughout the year? Is that what you're saying?
Yes.
And you were asked about postpartum psychosis, and you said it was rare. How rare is it?
I'm not sure the statistic, but low.
Well, have you dealt with patients in your 4 years of residency that had other types of psychosis?
Yes, many.
And psychosis, whether it's from postpartum or some other mental illness, does it present the same, or does it matter what the underlying illness is?
I mean, it can present different based on the individual, but it's the same general disorder.
And so what are the symptoms or signs that you look for to determine whether someone has psychosis?
So you look at them, you assess their appearance, are they disheveled, and then you look at how cooperative they are, how they're engaging in your interview, are they answering your questions or maybe refusing to answer your questions, maybe being very aggressive. You look at their speech, whether they're speaking very fast, very loud, or the opposite, like maybe not really even speaking much at all. You look at what their thoughts are like, and we assess thoughts by what they're saying. That's how we know what people are thinking, and whether what they say makes sense linearly, or whether someone's jumping around and you can't follow them. We also assess the thoughts for their content. If someone is speaking about things that are very bizarre, things that are very paranoid, if someone is talking or making noises, or it seems like they're communicating with somebody that's not in the room, those are all things, behaviors that we assess for.
So although you'd never treated someone with postpartum psychosis, you had evaluated, diagnosed, and treated people with other types of psychosis. Is that correct?
Yes.
Did you see any signs of psychosis in any of your interactions with Lindsay Clancy?
No.
Defense counsel mentioned that part of your residency was during COVID. Did mental health issues just stop during COVID?
Of course not. They often got worse.
And so it's fair to say you still kept busy seeing patients on a daily basis?
Yes.
You also mentioned that some of the patients you saw in your residency, it was outpatient care, is that correct?
Yes.
Is that similar to the care you were providing to Lindsay Clancy?
Yes.
And was that all 4 years you were providing outpatient care to psychiatric patients?
For 3 of the 4.
You were also asked about telehealth. Is telehealth appointments in psychiatric care standard in the industry?
Yes.
And how long has that been standard?
Since COVID.
And is it a fairly common and accepted practice at this point?
Yes.
Most of the session, for a psychiatric session, you're talking to someone, right?
Yes.
Does looking at someone through a computer screen somehow inhibit how you hear the answers?
No, it does not.
Or inhibit the way you ask your questions?
No.
And defense counsel asked you about, not being able to see below the waist someone's shaking or moving, but if someone's sitting and they're bouncing, can you see it elsewhere? Can you see other movement?
Yeah, sometimes it can reverberate in different parts of the body.
You were also asked about the Edinburgh scale. You said you don't use it, right?
Yes.
You said you use the PHQ-9. Why do you use that instead of the Edinburgh scale?
It's not my choice. That's the practice at Astor of what we use.
And the PHQ-9, what does that look for?
It assesses various symptoms of depression.
And postpartum depression, are there questions on the PHQ-9 that look for the signs and symptoms of postpartum depression?
Not specifically postpartum depression, but the symptoms of postpartum depression are symptoms of depression that occur during postpartum. It's the same symptoms.
So the PHQ-9 is asking the patient questions that would reveal whether or not they might be depressed, but not whether or not they just had a baby.
Correct.
And then with your interaction with the patient, you're able to know whether or not they are in the postpartum phase.
Yes.
And so would it be fair to say that you take the PHQ-9 plus the information you learn from the patient, put it together and come up with a diagnosis?
Yes.
When you take a history from a patient, you were asked about taking history from Ms. Clancy. How important is it that the patient give you accurate information?
It's very important.
And why is that?
Well, that information is being used to make treatment decisions, and a lot of things can be assessed. The things that I described before. That's very helpful, but we can't see what someone else's thoughts exactly are. So the person does have to tell them to us.
And would you agree that people in the medical field, such as nurses, are acutely aware of the necessity of an accurate medical history and symptom presentation?
Yes.
You mentioned that the defendant was able to advocate for herself. In what ways did she show you that?
In scheduling her own appointments, in presenting herself to the emergency room when things were really not going well, in different
Is or therapy sessions, conversation, script or conversation?
it's a conversation.
Providing therapy to someone like Ms. Clancy, is that dependent on what she's telling you and then how she's responding to what you're saying, basically a conversation?
Yes. Therapy is a lot of listening.
Would you say it's more important in therapy for the psychiatrist or therapist to talk or listen?
Listen.
And why is that?
Because that's how you really understand what a person is feeling.
Now, is it accurate to state that in every one of your sessions with Ms. Clancy, you told her about individual therapy and encouraged her to attend individual therapy?
That was the treatment recommendation each time. I'm not sure if I explicitly mentioned it each time, but I did many times.
And you, in fact, wrote it on the work form that we talked about previously on page 104 of the records. It lists, was the patient referred to other healthcare providers for evaluation or treatment? It says yes. If yes, state the nature of such treatments and expected duration of treatment. And it says individual weekly therapy, correct?
Yes.
And this is the form that the defendant asked you to fill out, correct?
Yes.
And you sent it back to her, and the first version she wanted you to make some corrections on, correct?
Yes.
But she didn't ask you to change that portion, correct?
No.
And in fact, on the second version, on page 107 of the record, it still says individual weekly therapy recommended, correct, for follow-up?
Yes.
Would it be accurate to state that the defendant only saw Jennifer McAllister twice the entire time that she was with your practice for therapy?
Yes.
You were asked about Zoloft being used for general anxiety disorder. Is that a common drug used for general anxiety disorder?
Yes.
And why is that?
Because it's effective and it's safe.
You were also asked about the suicide warning on it, that there is a suicide warning. Is that for all ages?
No.
What ages or groups is that suicide warning for?
It's really for children and adolescents. They do say up to 24 years, but it's really children and adolescents.
Would it be accurate to state that the defendant was 32 years old when she saw you?
That sounds right.
Well, if you want to check the records,
I can check.
to be sure.
Yes.
Is that correct?
Yes.
Okay, so 32 years old is not 3 to 4 years older than 24, correct?
No.
Why didn't you have to titrate the 50 milligrams of Zoloft?
You mean to stop it?
Yes.
Because it's still a very low dose, so it can be stopped right away.
So it wasn't necessary?
Not necessary.
The defendant waited about a month after receiving the prescription before taking the medication, correct?
Yes.
And she only took the medication when she decided she was ready to take it, correct?
Yes.
So she was taking in the information you gave her, correct?
Yes.
She was making her own decisions, correct?
Yes.
She was not forced to, correct?
Yes.
She actually had an appointment in between when you first prescribed it and when she started taking it, where she was still discussing with you whether or not she wanted to take it. Is that correct?
Yes.
Is that part of the advocating for herself that you were talking about?
Yes.
Is that part of the medical sophistication that she possessed that you were talking about?
Yes.
Your Honor, at some point, in light of the fact this is direct, I have to object.
Sure. Yeah, if you could just not ask the leading question.
Sure. I want to direct your attention to the September 12th, 2022 form that the defendant filled out. On page 16 of the record, we have different page numbers,
We
right?
do, but if you just tell me what you're looking at, I can find it.
The past psychiatric history.
Okay.
What did she tell you, Ms. Clancy, tell you about the, where it says, if yes, list the reason and dates? What did she tell you?
She said anxiety, September 2013 to September 2014, postpartum anxiety, May 2020.
And on the following page, under the past or current psychiatric medications, which ones did she list?
Prozac, 50 milligrams, and Wellbutrin, 100 milligrams.
Is there a column there that says effective yes or no?
Yes.
What was the defendant's answer with whether or not Prozac was effective?
Yes.
What was her answer as to whether or not Wellbutrin was effective?
Yes.
Is there another column there that said experienced side effects?
Yes.
Did she check off any side effects experienced for Prozac?
No.
Did she check off any side effects experienced for Wellbutrin?
No.
Going to the October 20th, 2022 appointment. You were asked about this on cross-examination about documenting side effects in your notes. Did you document the side effects that the defendant reported from the Zoloft on October 20th, 2022?
Yes.
And what did you document?
Well, I checked the box for GI, but I also talked about the side effects in the interval history.
And so what does GI mean?
Gastrointestinal.
So would that mean stomach issues?
Yeah.
And what did you put in your notes?
Couldn't sleep, insomnia, worse on increased dose, doesn't want to eat, diarrhea, food really unappealing, was more depressed on it, crying all day, yesterday, not normal, mental fog, terrified to start something new.
And so you did document the side effects that she reported to you, correct?
Yes.
You also documented in the interval history, paranoid of getting suicidal thoughts. Was that the defendant's phrasing?
Yes.
And is there a difference between someone being worried about having suicidal thoughts and someone actually having suicidal thoughts?
Yes.
And what's the difference in terms of how a psychiatrist sees it?
So that's the difference between what a patient might answer and then what the psychiatrist actually assesses. So say a patient might say they're having suicidal thoughts, but when they describe them, they're not actual suicidal thoughts. They're fears of suicidal thoughts. So that's the difference there. And I'm sorry, I think I forgot exactly what your question was.
So what's the difference in your training and experience between someone having fears of suicidal thoughts and actually having suicidal thoughts?
Well, so if it's a fear, then it means that they're not actually having suicidal thoughts. It's a negative.
And does that affect the way you proceed with treatment?
Yes, in some ways, yes.
How?
Well, you still proceed with treatment. It's still concerning, but it is a level of concern that can be managed on an outpatient basis, not requiring hospitalization.
And so, according to the defendant, she was not yet having suicidal thoughts at that time.
Yes.
So when defense counsel asked you repeatedly why you didn't document how many times she had those thoughts, she hadn't had those actual thoughts yet, correct?
Correct.
That was later in December, is that right?
Yes.
Now, she also told you that she was worried about something, that something bad might happen, so she arranged for her mother to stay. Is that correct?
Well, she arranged for her mother to stay. I'm not sure if that was because she was afraid something bad was happening, or it just seemed like they needed more help.
Okay. So you don't recall the two being together as a thought?
Correct.
And the fact that she was struggling and arranged to have her mother stay, got support, advocated for herself, would those be protective factors?
Yes.
How so?
So if someone demonstrates that they can advocate for themselves, that they can seek help if symptoms worsen, then that shows that they have good judgment. They can be trusted to present for care if serious safety concerns were to arise.
So based on your training and experience with Ms. Clancy, where she says she's worried about getting suicidal thoughts, and she has her mom come stay with her, do you see that as a positive decision?
Yes.
You were asked about not asking the defendant if she had called the suicide hotline. If a patient denies suicidal ideation, would you typically ask them if they had called a suicide hotline?
No.
And why not?
Because I wouldn't think that they would have. If a patient were to call a suicide hotline, I would think that they would be telling me they're having suicidal thoughts as well.
You were asked about prescribing hydroxyzine, Ativan, and Buspar. Did you tell the defendant how to take those medications?
Yes.
What were your instructions?
So the Ativan was to take as needed for severe anxiety. The Buspar was to be an everyday medicine. And the hydroxyzine, we had started that to see if she could use that as an alternative to the Ativan. So to take it instead of the Ativan. But if the if the hydroxyzine wasn't working, she still had the Ativan to use, it's stronger.
So was there ever an instruction for her to take all three at the same time?
No.
And you were asked about the contraindications of Ativan and Benadryl. Do you recall that?
Yes.
Are there contraindications for taking the two together?
It's not an absolute contraindication. You have to be careful that the person is not excessively sedated, meaning like they're so sleepy that it's hard for them to, engage in normal activities because they're so sleepy, or maybe they might feel a little bit dizzy. But it's not an absolute contraindication. You just have to monitor them.
And is that one of the reasons that you prescribed the hydroxyzine?
Sorry, is what one of the reasons?
Is the fact that the two of them together, Ativan and Benadryl. Well, let me strike that question. Why did you prescribe the hydroxyzine?
So she had been taking Benadryl, which is not a prescription medication. It's not classically within the scope of psychiatry, but it's very similar to hydroxyzine. So I thought that, hydroxyzine might be a better alternative than the Benadryl.
Okay, and I'm just going to direct you to your November 2nd, 2022 interval history. Now, would it be fair to say that on the November 2nd date, the defendant reported she was fine all day, evenings, bedtime, get anxious, Ativan helps, sleeping great on it, afraid to try something else, but knows it's not a long-term solution. Is that correct?
Yes.
And what part of that did the defendant tell you was not a long-term solution?
Taking the Ativan.
And why is that?
Because it was indicated for short-term use only. The people can struggle more with dependence if they're taking it for a very long period of time.
And was there a plan developed based on that concern?
Yes, there was.
What was the plan?
To reduce the dose by 0.25 milligrams every 2 weeks until she was off it.
So the defendant was able to express to you a concern she had about the medication, you had a conversation about it, and you addressed that with her and came up with a plan. Is that right?
Yes.
She also told you that day that she was in therapy and exercising daily, correct?
Yes.
Did the defendant ever tell you that she went to the South Shore Hospital Emergency Department on November 16th, 2022?
I don't recall that.
Did she tell you that they had prescribed trazodone to her at that time?
I don't recall that.
Did she ever tell you that she was trying some alternative methods like weed gummies?
No.
Do you have any way of knowing these things if the patient doesn't tell you?
No.
Now, on December 1st, 2022, defense asked you about that date. That's the date that she, again, said she had the fear of thoughts of suicide. Is that correct?
Yes.
Up until that point, had she consistently denied suicidal ideation or intent or a plan?
Yes.
Had she consistently denied homicidal ideation, intent, or a plan?
Yes.
What's the difference? Let me ask you this. When you talk to a patient, do you ask them, do you have suicidal ideation?
Not usually.
What do you,
not in that way.
How do you get that information from them? What types of questions do you ask?
It depends how the course of the conversation is going. I might ask if they're having thoughts of hurting themselves, if they, sometimes wish that they weren't alive. It can be a lot of different words, and sometimes I use, the patient's own words, but things like that.
And is there a difference between having thoughts of suicide versus having the intent and a plan to do it?
Yes.
And are there different types of treatment or things that you would do if someone has intent or plan to do it?
Yes, that would generally require hospitalization.
And so if Ms. Clancy had told you she had thoughts of hurting herself, or actually, if she told you that she had a plan to hurt herself or a plan to hurt her children, would you have moved to commit her?
Yes.
And that would be a Section 12?
Yes.
You were asked about the October 31st therapy session with Jennifer McAllister. And I know you weren't present from that. You're just going from the records. But you did say that in that session, the defendant denied suicidal ideation and homicidal ideation, correct?
Yeah, that's what's documented.
Would there be any reason, based on your training and experience, to do that further suicidal intent assessment?
No.
Why not?
Because if someone is denying suicidal ideation, they're just going to deny every other detail about suicide.
But that further evaluation, is that very specific questions about planning for suicide, how you do it, all of those things?
Yes.
Okay. You were also asked about evaluating the defendant for bipolar, and you said that she, based on your conversations with her, there were no signs of mania, correct?
Correct.
What are the types of questions you ask a patient to determine if they've experienced an episode of mania?
Well, a lot of it is what I can see in the session. I might also ask about some of those symptoms, like decreased need for sleep, or racing thoughts, or increased risk-taking activities. But even if they're reporting those things, I would have to really see it for myself to diagnose that.
And what would you see physically?
So I might see that the person is talking very fast, and it's almost impossible to interrupt their rate of speech. And it might also be very loud. They might be hyperactive, not able to sit still. They might be yelling and jumping from one thought to another without any linear connection between the thoughts. They might, I guess that's probably what I would observe in terms of behaviors.
Did you observe any of those behaviors with Lindsay Clancy?
No, it was the opposite.
What do you mean it was the opposite?
So, the opposite of euphoria is dysphoria or depression. The opposite of hyperactivity is tiredness and fatigue. So, in a way, it was the opposite of mania that I observed.
And in terms of the questions you asked about her past behavior, were any of the answers that she gave indicative of mania?
No.
You were asked about discussing Seroquel with the defendant, even though you weren't the prescriber. Why did you discuss that medication with her?
Because the patient was asking about it, and her husband was also asking me about it. They really wanted my opinions about it. It wasn't necessarily that I was prompting this line of conversation.
And what did you tell them about it?
Well, I shared that it has very good evidence for treating depression, and I may have shared that Seroquel does different things at different doses, right? So sometimes people are concerned that it is called an antipsychotic, but it actually doesn't function as an antipsychotic until you get up to really high doses like 800 milligrams. So in low doses, it's more of a sleep medicine or an antidepressant. So I think that I explained that to them, and it's obviously a very important part of it. But they were also concerned about that causing the depression that she was experiencing. So we talked a bit about how you would tell. It kind of can be hard to tell whether a medicine is causing that or it's just occurring because of depression.
What did you tell them in terms of how to tell?
That it's really based on the timing. If you were to notice a significant decline after starting or increasing the medication.
And prior to Ms. Clancy taking the Seroquel, had you noticed signs of depression in her?
Yes.
And after she was off of the Seroquel in January, did you see signs of depression in her?
Yes.
So that was completely off of Seroquel both before and after, still showing signs of depression? Yes. During January, the defendant told you she had trouble getting out of bed?
Is there a specific visit?
I think it was right after she got out of the hospital. Maybe your first or second visit with her.
I see that on the 16th, she did say that she was able to force herself out of bed and take care of basics, so on and so forth.
Were you aware that she had gone to the Museum of Science with her family on January 8th and spent a few hours there interacting with the exhibits and the children?
No.
Were you aware on January 15th, the day before that session, she had been to the Cape Codder down in Hyannis with the family, interacting with the kids and going down little water slides and all of that?
No.
Were you aware that on January 14th, she watched all three kids while Pat went to a brunch and was fine?
No.
Were you aware that on January 16th, her husband took Cora skiing and she was alone with the boys all day and had no issues?
No.
You were asked about the thyroid and how that can affect mental health and postpartum. Were you aware that at both South Shore Hospital and Brigham and Women's Hospital, her thyroid limits were in normal range?
No, I was not.
You received a discharge from summary from McLean Hospital.
Yes.
What's contained in the discharge summary?
So it includes information about how the patient initially presented, what they said when they first came to the hospital, and their initial assessment from the psychiatrist that they spoke with. It talks a bit about their course, their treatment course, how things progressed, any changes that were made, and then it talks about how the patient appears on the day of discharge.
Does it also include what medications they were prescribed and what the diagnosis might have been?
Yes.
And was that sufficient in terms of your review of the information that you needed for you to know about your patient at that time?
Yes, that was a very helpful amount of information that I would typically review that amount of information for a patient after the hospital.
Now, you were asked about your January 23rd, 2023 session with the defendant. Defense counsel asked if you had, recommended a hospital evaluation for her on that day, and you said no. Why not?
Because she was completely denying any suicidal ideation or homicidal ideation. There were no signs of psychosis or mania, so there were no serious signs that her safety or that anyone else's safety was at risk.
And during that session, did she ever tell you that she planned to harm herself or the children?
No.
If she had done that, what would you have done?
I would have, it depends exactly how it would have played out. It would definitely include hospitalization. If the children were in immediate harm, it might include enlisting help from my staff so that they could call the police while I'm on the phone with her. I think it depends, but I would address it promptly.
You were asked by defense counsel about the amitriptyline that you prescribed on January 16th, 2023. That initial prescription was for 10 milligrams, correct?
Yes.
Pulling the bottle from exhibit 155 of amitriptyline. Would you agree with me that this shows that the prescription was filled on that same day, January 16th, 2023?
Yes.
And out of this pill bottle here, there were 30 pills in this prescription, correct?
Yes.
And there are 8 pills missing from this bottle. So filled on January 16th, 16th, 17th, 18th, 19th, 20th, 21st, 22nd, 23rd would be 8 days, correct? Mm-hmm. And on the 23rd is when you said she could raise it to 20 milligrams?
Yes.
So if there are only 8 pills missing, she never took that additional dose, correct?
That's what I would think based on what you just said.
So the amitriptyline, increasing it from 10 milligrams to 20 milligrams, wouldn't have pushed her over the edge, correct?
Well, if she didn't take 20 milligrams, then that's correct.
I have nothing further, thank you.
All right. Then recross.
Briefly. So one of the questions that prosecutor asked you pertained to whether or not you could reach out to a third party. You recall that question, like mother, father, husband?
Yes.
And we already on cross talked about that you didn't, and they didn't call you, but then the DA also raised that, and you said you didn't have HIPAA permission. You recall just telling that to the jury?
Yes, that was an additional detail.
All right. So what does that mean?
Well, HIPAA is the privacy law for patients, which we have to respect and honor very diligently. So we are not allowed to talk about a patient's treatment to anyone. We're not even allowed to say that they are a patient at our clinic unless they were to waive those HIPAA rights.
And she was very cooperative, would have been more than willing to have you talk to her mother and father and her husband, right?
Objection.
Sustained.
Well, did you ever ask her to sign a HIPAA form?
So that was not the main reason why it wasn't done. It wasn't.
Did you ever ask her to sign
A release, you mean?
Yeah.
Yes. No, I did not ask her to sign a release.
And if she did sign a release, even though her mother, her father, her husband didn't call you, you could have then reached out to them, right?
I could have, but it is not typically something that is done when you have an adult patient who's able to speak for themselves.
Yeah, what is that? It's not typically done when?
When you have an adult patient who is able to speak for themselves.
My God, you don't call the parents that she's living with because they're helping her or her husband?
No.
Because why? She's able to advocate for herself?
Yes.
Prosecutor yet again raises the issue of the marijuana. You recall that question?
Yes.
She wasn't smoking marijuana, was she?
She did not tell me she was smoking marijuana.
Did she tell you that she was using marijuana?
No.
Did she tell you that she was using gummies?
No.
Did she, because gummies in plural is what the DA asked you, right? She was using gummies?
Yes.
Now, I asked you about getting access to the woman and infant's hospital records, which you did not. Which you did not, right?
I did not.
And we already went over that. You could have, if you asked for them with a HIPAA form, right?
Objection. Didn't ask about those records.
I don't care if she asked about the
Beyond the
records.
scope.
Overruled. You can ask that question.
She asked you about marijuana gummies, right?
Yes.
Okay. Your Honor, I would offer the woman and infants hospital records from Rhode Island dealing with Lindsay Clancy.
No objection.
Okay, they may be admitted.
I just want to look at them at some point to make sure it's a clean copy.
Sure, yeah. Before it goes to the jury, you can review it.
And it's important for a patient to be forthright when asked questions by their provider, right?
Yes.
And you always, in your opinion, found her to be forthright, right?
Yes.
Okay. If I could approach you with Exhibit 220, excuse me, and see the second paragraph, it begins in the middle of November. Could you read that first sentence?
In the middle of November, she tried taking a marijuana edible to help her sleep, which caused her to have increased anxiety and palpitations.
So, the records, if you had obtained them, you would have seen that it was not marijuana, it was not gummies, plural. It was one gummy that she tried, and it didn't work out, right?
Based on what I just read, yes.
Then you told us that there's a difference between a thought of suicide versus a plan of suicide, one of which would result, in your words, were a commitment, right?
Yes.
What does that mean? Thought versus plan equals commit.
A suicidal plan means that they are, they know exactly what they're going to do to end their life, what they're going to use, maybe when they're going to do it, they've researched it, and that presents an immediate threat, and that is something that would require hospitalization.
District Attorney had asked you also about the thyroid levels, and you indicated, or she indicated, that They were in the low range at Mass General Hospital, Reed, is that correct?
I thought she said they were normal.
Oh, I thought she said low, but normal or low, MGH, Mass General Hospital, right?
Sorry, what's the question?
District Attorney asked you whether or not they were thyroid reads. Do you remember that question?
She said her thyroid had been tested.
My question now is, do you remember that question that she asked you that you answered with no problem?
Yes.
Okay. And your response was that, my memory, as jurors it counts, that it was low reads, MGH, and South Shore Hospital. Is that right?
I thought she said that it was normal or within normal limits.
Almost fine. We'll go with normal. So your memory is that there were thyroid blood level reads of Lindsay Clancy from 2 healthcare providers. Is that correct?
Yes.
One would be Mass General Hospital, right?
I don't remember exactly. I think she said yes. I think she said Mass General.
Okay. Do you remember where the other hospital healthcare provider was?
It might have been South Shore.
Do you know what date those were?
No.
Those are old reads, weren't they?
I don't know.
One of the things that the district attorney asked you about on a number of occasions that seems to be important